50 to 100 milligrams IV every 6 to 8 hours. If it's more of a chronic process or they're not as symptomatic, we need to replace their cortisol production. And again, just like you would replace insulin and mimic physiologic production of insulin, when you're replacing cortisol, you have to mimic the physiologic production of cortisol. So you could use hydrocortisone or prednisone, higher doses in the morning, lower doses in the evening, just like you're mimicking the cortisol production. And patients can also be given a dexamethasone IM syringe, kind of like a Narcan thing or an EpiPen type thing, that if they become symptomatic for whatever reason, they have it there for an emergency situation. The adrenal medulla also produces hormones, and the adrenal medulla hormones are the catecholamines, right? Catecholamines are what it produces. It produces epinephrine and dopamine. Epinephrine, we know, activates the sympathetic nervous system, which is an activation of all alpha and beta receptors. And we know that dopamine breaks down into norepinephrine and then activates the alpha 1, alpha 2 receptors, which causes an activation of the sympathetic nervous system, but mainly vasoconstriction, right? So what disease do we talk about with adrenal medulla disorders? There's only really one disease that is always a testable question. We've learned about it in undergrad. I'm sure you learned about it again in grad. And honestly, for most of us, we will probably never see this disease process in our entire lives. It is such a rare disease, but when left untreated and not recognized, it is deadly. So that is why, it's focused on so much, but you will most likely, most of us in this room have and will never see it in our practice. But what a pheochromocytoma 2, it's usually a benign tumor that sits on the adrenal medulla, and it causes excess release of catecholamines. About 10% of them are malignant, but most of them are benign. And think of the 5 Ps. That is going to be your signs and symptoms: persistent resistant hypertension, headache, tachycardia and tremors, profuse perspiration with flushing, and pallor due to vasoconstriction, right? So think about what's happening here physiologically with your patient. If you need to remember the signs and symptoms of pheochromocytoma, imagine if you were to give your patient boluses of epinephrine and dopamine like every 5 minutes. Just keep bolusing them, right? Just keep bolusing them with that. What is your patient going to look like? That's what's happening here. So your 5 Ps are going to be your diagnosis. Diagnostic abnormalities, usually will run a 20. This is usually a diagnosis of exclusion, which makes sense, right? They'll run a 24-hour urine, and they will be looking for urinary metanephrines and urinary venoleic acid, VMA. Urinary metanephrines is going to measure the amount of unused catecholamines. VMA is the breakdown of the used up catecholamines, right? And if they're greater than 2 times the normal limit, then they recommend a CT scan or MRI specifically of the adrenals. If you put that in the comments to MRI or CT and you're focusing on the adrenals, then they will be able to focus down and give you certain cuts that are important for those adrenals. And that would confirm the diagnosis of the pheochromocytoma. Remember, anytime you're ordering some type of diagnostic study, like a CT or MRI, you really want to make sure, when I'm ordering, say I'm ordering a CT of the abdomen or I'm ordering a CT of the chest in trauma, right? There is a button in, we use obviously electronic health record, and there's a button when it asks for the reason, I can just click on trauma, and that's fine. They will accept that, right? So if I order, say, a CT of the abdomen and pelvis, and I just click trauma, they will they will look for that, and that's fine. They accept that as a reason. But the more information you give the radiologist, the more information they're able to get back to you, right? So if I am looking for something specific, like maybe I'm doing a chest x-ray and I'm looking to see if there's a resolution, it's a post chest tube pull, and I'm looking to see if there's resolution of a pneumothorax. If I say that to them, that gives them more information to go on. Or if I'm doing a CT of the abdomen and pelvis and I'm looking for something specific, I am concerned about something. If I put it in there, that gives them a bigger, they're obviously going to look at the whole picture, but then they will also take some time to look down into what it is that you're ordering, which makes their job so much easier and you to get more likely the results that you need to do information with, right? To do what you need to with information. So Just saying general trauma. Well, they could be looking very general, but if I'm looking for something very specific and I put that in there, the more information you give, it's kind of like a computer system, right? You only get out what you put in. The more information you give to the radiologist, the more then they're going to say, okay, well, they're looking specifically for this. Let me, I did my whole evaluation. Let me go back and just double check here because I know this is what they really want me to focus on. And let me take a much closer look. And they might find something very, small or minute that in a general evaluation probably wouldn't be picked up because it wasn't significant enough, but it makes a difference to you. So the more information you give them in diagnostic studies, when you put those reasons in, the better outcome you're going to have, the better information you're going to get for your results. Okay, just a little side note and whatever. Treatment for pheochromocytoma. The definitive treatment is to remove the tumor, right? That's a definitive treatment. When they're going for tumor removal, need to make sure that they are volume expanded because once they remove that tumor, they will stop with those boluses of their catecholamines, and then we don't want them to again go into hypovolemic shock, right? Symptomatic treatment, we start by controlling the alpha receptors first. So once hypertension has been resolved, then we can follow with beta blockers to get more heart rate under control, right? You don't want to start with alpha and beta blockers and then have unopposed alpha stimulation, which was going to cause severe hypertensive emergency. So get the vascular stuff controlled with the alpha blockers first, then start beta blockers after. All right, and then disorders of antidiuretic hormone. Any questions before we move on to disorders of antidiuretic hormone? We will get to medications for alpha blockers. So hold that question for a second. You're welcome. But yes, there is a preferred one. All right, let's look at disorders of antidiuretic hormone. And in this case, we're going to be talking about diabetes insipidus and SIADH. Diabetes insipidus. So what's the role of antidiuretic hormone? Antidiuretic hormone helps us to control our fluid balance, right? So that you're not just constantly expunging fluid all day long. It helps the kidneys to recognize enough fluid went out, we need to retain some fluid, right? So diabetes insipidus, you either have insufficient ADH or the kidneys are not sensitive to ADH. There are central and nephrogenic causes. Nephrogenic causes are usually genetic in nature, where the kidney just doesn't respond well to ADH and doesn't hold on to fluid. But a lot of cases, the drug lithium is the culprit. There is some other medications that can do this, but lithium, patients with psych disorders who are on lithium, and we're seeing much of a higher use of lithium now, we have to look for diabetes insipidus if they become symptomatic. Central causes is usually caused by damage to the pituitary gland or the hypothalamus. And this could be post-surgical, meningitis, head injury, very common. So think about, you have antidiuretic hormone that's stopping the flow of fluid out of your body, right? Controlling it. Now you have insufficient ADH or your kidneys are just not sensitive to ADH. Now you have plasma-free water depletion. And these go back to our sodium labs, right? So now you have plasma water depletion, right? So you're going to have really thick concentrated serum. You're going to have thick concentrated serum, which makes it hyperosmolar, and they're going to be hypernatremic. Then in their urine, because it's all free water, they get hyponatremic and hypoosmolar, right? Typically, you're going to look for signs and symptoms of hypernatremia and dehydration. Treatment is usually supportive. It's just you fluid replace them until the underlying condition resolves, and then you can replace ADH in the form of DDAVP if they are severely symptomatic. SIADH is also commonly caused by head injuries. So head injuries can go either way. Head injuries can go into diabetes insipidus. They can go into SIADH. They either knock out the pituitary or they aggravate the pituitary. Think about it that way when they hit their head. It just depends. It's the run of the mill. I tend to see more SIADH in head injuries than I see DI, but both can happen, right? Sometimes, in the ICU setting, when they're in the trauma ICU, we see more diabetes insipidus than we do SADH. It's kind of like this back and forth thing, right? The other thing that it's caused by is lung cancer, specifically small cell lung cancer, which releases enzymes that release more ADH and ADH-like products. So if you have SIADH, you have too much ADH production, which causes you to hold on to way too much fluid. Then it results in volume overload, which dilutes out your serum. So you get hyponatremic hypoosmolar. And in your urine, it's going to be very concentrated with hypernatremia and hyperosmolality, right? So opposite labs for these two. Symptoms with fluid overload and hyponatremia for SIADH. Most SIADH just requires free water restriction in most cases, right? You can use in more severe cases loop diuretics with normal saline. So you use the loop diuretic, and then once those floodgates open, you're like rehydrating them with normal saline. But in most cases, 1 to 1.5 liters per day fluid restriction will, until everything resolves, will be perfectly fine. In very severe hyponatremic symptoms, 3% normal saline could be utilized. I will tell you, if you've never used 3% saline before and you don't know what you're doing with 3% saline, please get help. It is not something that you want to accidentally misdose. I mean, you literally can kill somebody within minutes giving them the wrong dose of 3% saline. So really, in most instances, if you're pulling 3% saline, it's coming usually from the pharmacy that is requiring, a lot of information before they're just going to give you a bag of 3% saline, right? But in some units, like if you work in a neurosurgical unit, 3% saline is more readily available in those units because they use it more often, or trauma units have 3% saline more regularly available. If you work in a typical medical ICU or med surg unit or something along those lines, or even the ER, 3% saline is not usually stocked regularly because it is very dangerous to use if you don't know what you're doing. Like I said, you can literally kill somebody in minutes giving them the wrong dosage. So not to scare you, but maybe to scare you a little bit. So you make sure you're getting the help that you need, right? All right. Any questions there before we go into an array of questions about different endocrine disorders? All right. I don't see any, so we are going to move on. Page 43, your first question of endocrine, or really your fifth question, but your fifth question in the chapter. While on call, you are paid to the ED to evaluate a 37-year-old female with a history of Graves' disease. She has been non-compliant with controller therapy and now presents with tachycardia, hypertension, palpitations, and overt anxiety. Immediate treatment should include what? So she has a history of Graves, so we're thinking hyperthyroidism. She has been non-compliant with her controller therapy, and now she's tachycardic, hypertensive, palpitations, overt anxiety. We need initial treatment, which is going to be propranolol, right? In some cases, maybe corticosteroids, but initially we need to get her symptoms under control, which would be the beta blocker. Surgical intervention, even if we need to do a further intervention with this, Graves' disease is not likely to have a surgical intervention. PTU is an option, but obviously she's been non-compliant, so we need to treat her symptoms. Question number 6, a 54-year-old male patient with a low TSH and elevated T4. What signs and symptoms do you expect? So low TSH, elevated T4, we're thinking hyperthyroidism. Exophthalmos, tachycardia, hyperreflexia. Well, yep, that makes sense, but we always read all 4 answer choices, right? Bradycardia, no, they don't get bradycardic, so we can cross it out. Constipation, nope, they don't get constipated with hyperthyroidism, so we can cross that out. Nausea, maybe. Decreased visual acuity, polyuria. That's sounding more like what? That's sounding more like a diabetes type situation. So letter A is the best choice for hyperthyroidism. Your patient has hypothyroidism. You're treating him with levothyroxine. Which of the following value would you follow to determine if his treatment is adequate? And we talked about this. I really don't have much more to say about it. It's direct from the guidelines that the guidelines tell us as a generalist provider, you're following the TSH, and nothing else should really matter to you. And if you want to draw other things, those are patients that should be going to endocrine. That's per the endocrine guidelines. All right, diabetes insipidus would most likely be characterized by which of the following sets of laboratory values? So diabetes insipidus, when we think about diabetes insipidus, what are we thinking of? We're thinking of dehydration. So we're thinking of serum hypernatremia, serum hyperosmolality, and then urine hyponatremia, urine hypoosmolality, right? So reverse the labs. So let's look at this. So serum glucose of greater than 200. Well, I don't know. Maybe, maybe not. That's not really like diabetes insipidus specific, but let's read the rest. Urine osmolality of 330. A normal random urine osmolality would be 300 to 900. So that is a normal urine osmolality. And what would we expect in diabetes insipidus? We would expect hypoosmolar urine. So that doesn't make sense. We can cross out letter A. How about a serum sodium, letter B, of 125? Well, we know they should be hypernatremic in the serum. So that doesn't make sense. We can automatically eliminate letter B. So serum osmolality of 330. That would make sense with diabetes insipidus, right? They're hyperosmolar. A serum sodium of 160. Remember, normal random urine sodium is 10 to 20. So 160 would definitely be what? The serum sodium would, or I'm sorry, I skipped to urine sodium. Serum sodium 135 to 145. So definitely hypernatremic in the serum, right? Urine sodium is 5. So 10 to 20 is that normal range. It's low, we would expect that, right? We would expect serum hyperosmolality, serum hypernatremia, urine hypoosmolality, and urine hyponatremia. So letter C looks like our best answer, but of course we always read all four. Serum potassium of 3, I don't know. Urine sodium greater than 20? No, that wouldn't make sense. That'd be more SIADH. So for diabetes insipidus, our correct answer would be letter C. Question 9. A patient in ventricular fibrillation is failing to convert despite repeat attempts at defibrillation. Which of the following underlying endocrine abnormalities is most likely? Type 2 diabetes, Addison's, hypothyroidism, or Cushing's? This one you got to think through a little bit. I mean, all of them you do, but this has a couple parts you need to think through. What we need to think through is they're in VFib. They're doing repeat attempts at defibrillation. They're not converting. And we're looking for an endocrine abnormality that might cause this. The correct answer here is Cushing's. So in Cushing's, they become hypokalemic, which can lead to ventricular fibrillation. Hypokalemia is also the most common cause of defibrillation not being effective, right? So Cushing's syndrome would be the correct answer there. The definitive treatment of choice for patients with pheochromocytoma is what? Phenoxybenzamine, propranolol, tumor removal, or levothyroxine. So we said definitive treatment, the curative treatment would be tumor removal, right? This is the meds that would be used. So phenoxybenzamine, that is the alpha that is preferred, and propranolol is the beta that's preferred. Remember, alpha control first, then beta control, right? And levothyroxine just doesn't make sense. CT scan of the adrenal glands would most likely identify patients or abnormalities in a patient with what? So from CTing the adrenal glands, it's most likely going to identify abnormalities in a patient with what? Is it acromegaly, Kawasaki's disease, Addison's disease, or prolactinoma? I think we actually talked about this, that it'd be Addison's disease, small, shrunken adrenal glands. Acromegaly is a pituitary issue, increased release of growth hormone. The Kawasaki's disease is an is an autoimmune vascular inflammation. And prolactinoma is increased prolactin from the pituitary gland. It's a tumor. It's actually a tumor that causes the pituitary gland to release prolactin. Usually this is found in females that have failure to conceive and have irregular menses, usually during an infertility workup. Question number 12. Diabetes insipidus is caused by dysfunction of the what? The adrenal medulla, the adrenal cortex, the pituitary, or the thyroid? And with diabetes insipidus, it is the pituitary gland, right? The pituitary is not releasing ADH typically, if it's a central cause, right? Adrenal medulla would be pheochromocytoma. Adrenal cortex is going to be your cortisol disorders, your Cushing's, your Addison's, and then thyroid is obviously going to be thyroid. Question 13. A 65-year-old male patient with a history of small cell lung cancer is sent to the emergency department from an infusion center with a serum sodium of 130. Patient is awake, alert, and oriented. Patient reports a sudden decrease in his urine output over the last few days. Further laboratory analysis reveals a serum osmolality of 260 and a urine sodium of 35. Which of the following interventions would be most appropriate for this patient? All right, so small cell lung cancer, serum sodium of 130, wake, alert, and oriented, sudden decrease in urine output over the last few days. Serum Oz is 260, urine sodium is 35. So what are we seeing here? We're seeing in the serum, we're seeing hyponatremia, right? We're seeing hypoosmolality. And then in the urine, we see a urine sodium of 35, which is hypernatremia, right? So increased sodium in the urine. So what are we leading towards here? This sounds like with the underlying diagnosis plus those labs, he could be an SIADH patient, right? So fluid restriction, loop diuretics, normal saline, 3% normal saline, insert a Foley catheter, monitor urine output for 24 hours. Well, we already said letter D, we never pick that type of answer, right? So we can automatically cross that off. So let's look at the patient's symptoms. The patient is awake, alert, and oriented. The patient just has a sudden decrease in urinary output. So what's our goal here? Probably just some fluid restriction, right? If he was starting to get a little bit more fluid overloaded, we could do the loop diuretics. And if he was severely symptomatic of the hyponatremia, obviously 3% normal saline. Which of the following diagnostic studies confirms the diagnosis of pheochromocytoma? Is a CT scan of the adrenals, dexamethasone suppression test, coscotropin simulation test, or decreased TSH? Which one is it there? The diagnostic study that confirms pheo is a CT or an MRI of the adrenal glands, right? Serum TSH levels obviously would be for thyroid disease, right? And then the dexamethasone suppression test would be for Cushing's. The coscotropin simulation test would be for Addison's. All right. There are some credits and references which are available to you in your book. Any questions? What questions do you have? Right, I am getting ready with the next set of slides here. Okay. All right, no questions? Then we are going to move on. All right, so we have finished chapter 2 and we have made it through endocrine. We're going to be moving on to chapter 3, which is hematologic and oncologic disorders. Okay. Couple things that we're going to talk about, some just there honestly as a reference point for you. Blood product transfusion. We'll talk about some issues with blood product transfusion, but as far as blood products themselves, there is a whole list there for you that's going to be more of an FYI. Talk about our typical anemias, our sickle cell anemia, our platelet disorders, and then we'll talk about lymphoma and leukemia specifically. Okay. So we start with blood product transfusion, and this starts on page 48 of your workbook. Blood product transfusion, I just gave you a chart of all the different types of blood products and the information about when they're used, what their clinical utility is, and a description of them. I don't feel going through these and reading these to you is useful. This is just something that people have asked me for in the past to understand the differences between all the blood products. So I put this together. It is here for your reference. If you need a clinical reference, feel free to refer to that. Some of you might be very familiar with it and don't need that at all. But either way, I don't feel like just sitting there reading to you this information is going to like cement it in your brain or really give you any like extreme benefit, right? So it's there for your use, and if you need that reference material, it'll be perfect. Otherwise, you can just ignore it and move on if it's something you already feel remarkably comfortable with, right? So we are actually going to start on, when it comes to blood products and blood product transfusion, what are some of the things that we need to think about? And obviously, we need to think about reactions, right? We need to know when it's appropriate to give blood products, but also we need to be thinking about what are reactions. And there's three different types of reactions that typically come from blood product transfusion: acute hemolytic reactions, allergic reactions, and transfusion-related acute lung injury, also known as TRALI. So let's start with acute hemolytic reactions. Acute hemolytic reactions usually occur within the first 24 hours after the transfusion. These are caused by an ABO incompatibility, where the patient develops antibodies against the donor's red blood cells. Presentation is a large fever, flank pain, and can also include acute renal failure. Aggressive IV fluids to flush that all out, maintaining a adequate urinary output. Diuretics and mannitol will help to maintain that urinary output. But you want to kind of basically flush that all out. Allergic reactions usually help, or usually they don't help. They usually start very quickly once they are exposed to the blood product, and it's reaction to the transfused proteins in the blood. And the symptoms are going to be allergic-based symptoms or anaphylaxis-type symptoms, such as urticaria, bronchospasm, laryngeal edema, hypotension, and anaphylaxis. If it's just urticaria alone, usually treated with diphenhydramine. If it is anaphylaxis, you're going to follow the anaphylaxis stuff that we talked about: epi, glucocorticoids, antihistamines, and then potentially H2 blockers and stuff like that. Now, with both of these reactions, with any type of, well, mainly with these two types of reactions, acute hemolytic and allergic reaction, there is a whole policy and procedure as far as what you have to do as the person administering the blood, right? Usually you stop the transfusion, you have to send samples, you have to draw a certain number of blood, you have to send it back down to the lab, the blood bank gets involved, and there's this whole process that goes on, right? So make sure you're following that process, but we're just talking about it from a bigger treatment perspective as well. TRALI. TRALI is a result of the donor having antibodies that bind to the white blood cells, causing aggregation in the pulmonary vasculature. When these white blood cells aggregate in the pulmonary vasculature, it causes an increased capillary permeability from mediator releases. And when there's an increased capillary permeability in that pulmonary vasculature, all the stuff that is typically filtered through those capillary beds gets stuck, and all this junk basically gets dumped into the interstitial spaces of the lungs, which is what we refer to as ARDS, acute respiratory distress syndrome. We will talk about ARDS most likely tomorrow. We'll start pulmonary today, but we probably won't get all the way through pulmonary today. So we will talk about ARDS tomorrow. And when we talk about ARDS, we'll talk about treatment there. But the presentation is going to be an ARDS presentation: acute onset of shortness of breath, non-cardiogenic pulmonary edema. You're going to treat them for ARDS, which again, we'll talk about ARDS treatment tomorrow. More likely, depending on where we are in time, maybe we'll start it early, but that's usually where I kind of like to say, you know what, let's take a brain break and we'll come back in the morning and reconvene, right? All right. So that's really reactions, but let's just do one question here. The AGA-CMP is evaluating an adult patient with symptomatic anemia requiring whole blood product transfusion. Patient is Jehovah's Witness and refuses all blood products. What is the most appropriate next step for the AGA-CMP to take in this situation? So you have somebody who's a Jehovah's Witness, refuses all blood products, needs a whole blood transfusion. What is your next step? It is, oh, I gave you the answer. I clicked too quickly. But it is letter C, educate the patients on the risks, benefits, and if there's any alternative treatments available. Whenever a patient's refusing, we have to respect their autonomy. And that's what we do. Here's the risk, here's the benefits. This is the risk of you not getting it. And this is, if we have any alternative treatments, this is what it is. Obtaining ethics consult is really not necessary, right? The patient has autonomy. The ethics is pretty clear. You don't just continue to monitor, and you don't want to have the patient sign out against medical advice. That's like retaliatory. That's really not a useful thing. All right. Any questions before we move on to anemias? All right, let's talk about anemia. Concepts of anemias. Obviously, know your normal hemoglobin values. We know a little bit lower in females than in males. Males typically have higher. There is, again, one typo on here that I want you to point out. Right where it says MCV 800 to 100, it's 80 to 100. There's an extra zero there. I left it there so it matches your book, but I want to make sure I pointed that out to you. So it's 80 to 100. The red blood cell indices, things that sometimes we don't really pay attention to as bedside nurses because they don't mean a lot to us, right? But when we're making diagnoses, they definitely mean a lot more. MCV, if you're not familiar with these red blood cell indices, start with the MCV. The MCV can give you a really good idea of what the potential anemia is that you're dealing with, right? The MCV tells me about the size of the red blood cell. If the MCV is 80 to 100, that tells me that's a normal size red blood cell or a normocytic cell, normal size red blood cell. If it's greater than 100, it's a macrocytic red blood cell, meaning it is a very large red blood cell. If it is less than 80, it is a microcytic red blood cell or a very small red blood cell. We'll talk about why that happens. Mean cellular hemoglobin concentration, this is the concentration of hemoglobin in the cell, and it's the color of the cell, right? It says, basically tells you what the color looks like of the cell. 32 to 36 is the normal value there. If it falls within that normal value, it is a normal red blood cell, right? Looks the normal red color that it should. If it's greater than 36, then it is a hyperchromic or very like beefy red blood cell, right? If it is less than 32, is a hypochromic red blood cell, meaning it's a very pale red blood cell. So it talks about the hemoglobin concentration within that cell, which lends to the color of the cells. And then the red cell distribution width tells me about the differentiation between all of the red blood cells and what they look like, right? So what happens is the human body, as it's producing red blood cells and other things, it wants them to all look perfect, right? It wants them to all look exactly like the other ones do. I kind of always equate this, me and my grandmother, who passed away about 3 years ago. She was almost 101. She was an Italian grandmother. And this time of year, especially, obviously, we would do Christmas cookie baking. And actually, a memory just popped up the other day that I was looking at, and apparently one year, I mean, we made 34 dozen Christmas cookies, right? I don't even remember who got all of these Christmas cookies, but I mean, I have a huge family, but like a huge family in general. But yeah, we made 34 dozen Christmas cookies, right? I will not be making, I still keep up the tradition that me and her did. I do it with friends of mine now, but because obviously she's not here. But I will not be making 34 dozen Christmas cookies. But if you've ever baked, right, and you're baking cookies, you have your bowl of batter, right? And you have this cookie batter that you're scooping out, making the cookies. And in the beginning, you're scooping them out. Maybe you're using a teaspoon or using one of those little teeny ice cream scoops, and you're scooping them out, and they're all the same size. And when they bake them and they come out, they all look the same, right? That's what the human body is trying to do. But as you're baking the cookies and as you get to the bottom of the bowl and you're like scraping the dough out of the bowl to like make cookie, they start to get, some are a little bit smaller, some might be a little bit larger, right? Because you're starting to run out of dough and you're trying to scrape the dough out and get enough dough to make a cookie. And sometimes it's too much, sometimes it's too little, right? That kind of thing. So a few of the cookies that you bake are not like, if you know the recipe makes 3 dozen cookies, the end of that 3 dozen of cookies, there's going to be a couple in there that just don't look like the other ones, right? They look a little bit different. Maybe you scoop some of the other ones a little too small. Now you're, whatever it might be. There's a couple at the end of that 3 dozen that are going to look a little bit different. Same thing with your red blood cells. About 11 to 14% of your red blood cells are going to look a little different than all the other ones, right? And that's okay. But if for some reason that number, the red cell distribution width, is bumped up to like 30% or 20%, you're going to look at that and you're going to say, there's 20% of the red blood cells don't look like all the other red blood cells, meaning either there is a disease process going on that's causing those red blood cells to look different, or the body's trying to overproduce red blood cells to try to make up for the fact that they don't have enough hemoglobin or something else is going on, right? So that is telling you that the body's overproducing red blood cells way too quickly, not taking its time and doing what it's supposed to do, basically. All right, so let's talk about the microcytic anemias, the macrocytic anemias, and neurocytic anemias. That's why if you can focus on the MCV, you can get through any of these for your boards, right? Macrocytic anemias, that's going to be your MCV less than 80. And that tells me the microcytic anemias with an MCV less than 80, that tells me really small red blood cells. And why do we get really small red blood cells? It's a problem with hemoglobin, right? So think hemoglobin problem. That is your iron deficiency anemia and your thalassemias. If the MCV is greater than 100, you then have a macrocytic anemia. And the problem there is not a hemoglobin problem, it's a problem with red blood cells, right? You're not producing enough red blood cells. If the patient's anemic and their MCV is 80 to 100, this is a normocytic anemia, meaning it is a normal size red blood cell. And the reason that we end up with a normal-sized red blood cell is because they are either losing red blood cells and hemoglobin at the same time, or there's an like some type of destruction of red blood cells and hemoglobin, equally. And that we see anemia of chronic disease and acute blood loss, right? So let's start with the microcytics. The microcytic anemias, iron deficiency is one of the most common. Common cause is slow chronic blood loss. The way that we make hemoglobin, you need iron and heme. Iron combines in the heme, you make hemoglobin, right? It's in a parallel process to your red blood cells being formed. If the patient has iron deficiency, they can't incorporate enough iron into heme to make hemoglobin, so they have a lack of hemoglobin. If you have a lack of hemoglobin, you're not filling up those cells with hemoglobin, meaning the cells are going to be smaller. Think of them as like a plastic shopping bag, right? Most common cause of iron deficiency anemia is chronic slow blood loss, not hemorrhage, but chronic slow blood loss. This can be from GI tumors, can be from GYN cancers. It can also be from a prolonged menstrual cycle, or we see this in pregnancy as well, right? Diagnostic findings: decreased MCV, decreased total serum iron, decreased serum ferritin, elevated total iron binding capacity, because there is more places for iron to stick to, or for iron to stick to that it's not doing it, and increased RDW, because the cells being filled with hemoglobin are smaller. There's not enough hemoglobin to fill all the cells. The cells are going to come out looking different, and the body overcompensates for decreased hemoglobin production by overproducing red blood cells. Common signs and symptoms: basically fatigue and pallor are going to be common signs and symptoms for most, if not all of these. The key symptom in iron deficiency anemia is that pica, right? Wanting to eat non-food-based products. Anything that really contains large amount of iron. It can be dirt, it can be cornstarch. I mean, I guess cornstarch is food, but nobody sits in front of the TV, at least that I know of, and watches a movie and spoons in spoonfuls of cornstarch. I don't know that anybody does that. But anything, it's almost like a primitive response. Anything that like has iron content, your body will want to chew on and suck that iron up from it. Identifying and correcting the underlying cause, especially with iron deficiency, is so important. If this is a person who's of an age or has a history that puts them at risk for colon cancer or for any of the GYN cancers, get them screened. One of the first things, if you diagnose a patient with iron deficiency anemia, send them to GI, get them a colonoscopy. They need a colonoscopy, right? If it's a female, they should also be going to GYN and having a thorough exam and making sure there's nothing there. Remember, it's usually a result of a slow chronic blood loss. You can replace iron, right? Give it oral, parenterally, whatever, but you can't ignore that there could be an underlying process. Hopefully they come back and their GYN exam is clear and their colonoscopy is clear, and there's just some other funky reason why they have iron deficiency. But you don't want to miss the fact that they have like a colon cancer or something like that. If anybody here has participated in, we've been doing a transition to practice series over the last year, and we're continuing it into next year. But we did like a grand rounds for the acute care provider. I did 4 sessions over the last year. If anybody came to them or if you're interested in them, they're there. They're available for purchase on the website to listen to. But we go through a case that is very similar to this and making sure you see the importance of this. But keep in mind, iron deficiency anemia, think colonoscopy, think GYN exam. Thalassemias. The only thalassemia I'm going to talk about is beta thalassemia minor. There is beta thalassemia major, which is really life-threatening. It causes a lot of, they're going to need multiple transfusions, usually reduced life expectancy. Then there's the alpha thalassemias that usually don't survive outside of the womb. So beta thalassemia minor is the common thalassemia that we see. It is basically a very benign condition, right? I actually have beta thalassemia minor, and I'm Italian. It happens in Mediterranean, individuals, so it makes total sense, right? Basically, with beta thalassemia minor, there is just a different production of hemoglobin. They produce a different genetic variation of hemoglobin, and they don't need as much of that hemoglobin, right? So somebody with beta thalassemia minor, their hemoglobin might hang around 9 or 10, and that's good enough, right? It's a genetic variation on hemoglobin. It's good enough. There is no requirement for, you would only transfuse anybody with beta thalassemia minor just like you would transfuse anybody else. With major, you would need routine transfusions. With minor, if they were anemic and symptomatic and needed transfusion for some other reason, then you would not transfuse them specifically for beta thalassemia minor. They have decreased MCV, normal serum iron studies, normal RDW because it's a chronic process and the body doesn't feel the need to correct anything, and it's diagnosed with a hemoglobin electrophoresis. I forget exactly which hemoglobin strain is the genetic variation because there's a couple. I can't remember it off the top of my head, but I think it's like hemoglobin. I don't even want to guess because I'm not 100% sure. But they can look under the hemoglobin electrophoresis and see exactly what genetic strain of hemoglobin this person has, and that's how they make the diagnosis. Signs and symptoms, there are no signs and symptoms. They're completely asymptomatic. Transfuse just as needed. Like, for instance, like I said, I have beta thalassemia minor. If I was in a major car accident, ended up in a trauma center and needed transfusion, or had major surgery and needed a transfusion because of it, then I would get a transfusion. But I don't need transfusions regularly. I've never had a transfusion in my life, knock on wood, right? Never been symptomatic, right? There's no treatment necessary. The one thing you don't want to do with a thalassemia minor patient is unless they have low iron for some other reason, you don't want to give them iron because they can become iron toxic. And genetic counseling for, if somebody in the future, they're going to have children or something along those lines and recessive disorders and stuff along those. The macrocytic anemias are your pernicious vitamin B12 anemia and your folic acid deficiency anemia. So you need vitamin B12 and folate to produce healthy red blood cells. If you don't produce healthy red blood cells, and then each red blood cell gets packed with more hemoglobin, and they become these large red blood cells. With pernicious anemia, it's a vitamin B12 problem. 99% of it is an absorption problem, right? So maybe somebody on metformin, somebody who had gastric surgery, right? Somebody for some reason has intrinsic factor antibodies, somebody who is not able to absorb vitamin B12. it's most likely that an absorption problem. It is very rare that a pernicious anemia is a dietary problem. Pernicious anemias do not usually develop from diet. Any animal product will give you enough vitamin B12 for quite a while. The only people that have problems with vitamin B12 in that circumstance then are strict vegans who get zero animal product, but are usually supplementing vitamin B12 in other ways, right? So it doesn't become a problem, right? Um, Diagnostic findings, we talked about elevated MCV, normal RDWs, low vitamin B12, low MMAs, or I'm sorry, increased MMAs and homocysteine, increased intrinsic factor antibodies, depending on the cause. Most common signs and symptoms here are those neurological signs, the stocking glove neuropathies and stuff along those lines. And supplementation of vitamin B12 is the treatment. Oral versus parenteral. Most people need parenteral, which is actually cheaper than buying oral vitamin B12. Figure that one out. But most people need parenteral because it's usually an absorption problem. If it's truly a dietary problem, then they can obviously take it orally. But most people, since it is a absorption problem, they need parenteral, not oral, because it's going to bypass the area of the gut that that absorbs it. Folic acid, this is typically a dietary deficiency or medication issue. We see this in alcoholism. We see this in the elderly with certain psychiatric medications. We also see this during pregnancies. Those are the times when we typically replete folic acid. It is a macrocytic anemia. You're going to see a normal serum vitamin B12, decreased serum or red blood cell folate, and normal MMA and homocysteine levels. The common signs and symptoms are listed here. The tinnitus is usually the key factor there. Identifying correctly underlying problem if possible. We can also see what, folic acid deficiency in certain leukemias. So you might want to rule out leukemia as well based on what you see in their blood and supplement folate. Then anemia of chronic disease and acute blood loss anemias. These are normocytic anemias. So the red blood cell is a normal size, right? In anemia of chronic disease, it's a common consequence of chronic illness. So renal failure, autoimmune deficiency, or any type of immune deficiency that autoimmune disorders or immune deficiency is what I'm trying to say, that causes either red blood cells and hemoglobin not to be formed correctly or just destroys them, right? Acute blood loss anemia, this is the one that happens from acute hemorrhage, so amputations, massive GI bleeds, stuff along those lines. They are losing hemoglobin and red blood cells at the same time. All of their diagnostic findings are going to be normal except a decrease in their hemoglobin and hematocrit, and obviously the red blood cells and stuff like that, but MCV, their indices are going to be normal. Treatment is going to be transfused as necessary for both of them. And for acute blood loss anemia, just like we talked about hypovolemic shock, treat the source and the cause of the shock or of the blood loss. Oh, somebody had a question. How common is iron deficiency from diet? I don't think we see really iron. It's not common at all from my knowledge, at least. Iron deficiency is usually not a dietary problem. Yeah, it's usually, like I said, the most common cause is that slow chronic blood loss. And I don't know if I explained why. I think I did, but just in case I didn't explain why, red blood cells, we get 85% of our iron stores from broken down red blood cells, right? So that's from broken down old red blood cells. That's where we get our iron stores. So if you have a slow chronic blood loss, you're losing 85% of your iron stores, right? I think I might have mentioned that, but I'm not sure that I did, so mentioned it now. All right, and let's talk about sickle cell anemia. This is a result of abnormal hemoglobin synthesis. So they have, just like thalassemia, a different type of hemoglobin. The hemoglobin that they make causes the red blood cells to sickle. And, as they pass through capillaries, typically red blood cells will collapse and re-expand. If you watch it under a microscope, it's kind of cool. You can YouTube a video. It's actually pretty cool. But sickle red blood cells usually flex and squeeze together and pop back open as they pass through the capillaries. When these they get sickled, then they're not flexible. They can't pass through those capillaries as easily, and they get microinfarcts, predisposing them to infection and anoxia. Sickle cell crisis is defined as an acute pain syndrome. treatment here is going to be around the prevention of crisis. Supplement folate in some circumstances to maintain good, healthy red blood cells as much as possible and keep them from sickling. In patients who have multiple episodes of sickle cell crisis, they can use hydroxyurea or hydrea for these extreme cases to prevent it. Actually decreases the number of uh, sickle cell episodes or exacerbation episodes that they have. Oxygen, IV antibiotics for infection, aggressive pain management. And what I want you to add here is IV fluids. IV fluids is like key, right? Keep everything flowing as much as possible. So add IV fluids to that bullet point there. All right, so let's do a couple questions and I'll see if you have any questions and then we'll take a break. I can't believe this day is like flying. I can't believe we've already gone through 2 more hours of content almost. But we have. All right, so identify the appropriate diagnosis for the following patients with anemia. So they're either going to be anemia of chronic disease, pernicious anemia, or iron deficiency. So here we have a 32-year-old woman with newly diagnosed lupus, systemic lupus erythematosus. Her hemoglobin is 10.1, which is a little bit low. Hematocrit is 32%, which is a little low. Red blood cells 33.2. MCV is normal at 82. MCHC is normal at 34.8. Red blood cell distribution width is normal at 12.1%, right? And I gave you the arrows and normal limits here just to help out a little bit. But is this anemia of chronic disease, pernicious, or iron deficiency? Well, the MCV is normal, so we know this is a normocytic anemia. Normocytic anemias, we're thinking what? Anemia of chronic disease and acute blood loss anemia. So there's our answer. And that matches up with the systemic lupus erythematosus, right? 70-year-old woman with a 4-month history of stocking glove neuropathy. Hemoglobin's a little bit low. Hematocrit's a little bit low. Red blood cells are low. MCV is 125.5, which means a very large red blood cell. MCHC is 31, which is normal. RDW is 18.8, which is elevated, right? So we have macrocytic anemia with that MCV of 125.5, right? So we're down to what? Vitamin B12 deficiency or folate deficiency, and it is the vitamin B12 deficiency, the pernicious anemia. It lines up with that stocking glove neuropathy, right? And the RDW is increased because the red blood cells are being overpacked with hemoglobin, so they all look a little bit different. Let's see. 68-year-old man who drinks approximately 4 beers per day, takes daily NSAIDs, and has erosive gastritis. So here we have a hemoglobin of 10.1, which is low, 32, which is a little low, red blood cells 32, or 3.2, sorry, which is a little bit low, MCV 72, MCHC 26.8, RDW 18.1%. All right, so this is a microcytic anemia, so we're thinking iron deficiency or thalassemia. Iron deficiency anemia would be the cause. And with that, they have erosive gastritis, taking daily NSAIDs, probably have a little bit of a slow chronic GI bleed going on there, right? The MCV is low, which makes it microcytic. Because there's lack of iron, there's lack of hemoglobin synthesis, which is going to make the red blood cells a little bit pale, which is going to decrease the MCHC, right? And then the RDW is going to be increased because the body's going to try to overproduce red blood cells. All right, and question number 3. A 25-year-old male patient with sickle cell anemia is currently admitted and being treated for a sickle cell crisis. The AGA-CMP understands the most important treatment for this patient during an acute crisis is what? Pain management, intravenous fluids, oxygen therapy, or folate supplementation. All of this would be important. Intravenous fluids is probably the most important, along with pain management, then oxygen therapy and folate supplementation, but really flushing that out to get things flowing so you can eliminate some of those micro infarcts. All right. So this is usually my breaking point, but I think what we're going to do, it's still just a little bit early for a break. I don't know. What do you guys want to do? It's 10 after. Usually I break at 3:30, and so we're a little bit ahead of schedule here, about 20 minutes ahead of schedule. Do you want to go through platelet disorders and oncologic disorders and make it up to 3:30 and then stop, or do you need a break now and take a brain break? All right, I see a mix of breaks and no breaks. So let's take a break. Just because if there's some people that feel they need a break, I want to make sure that they get it. And I see kind of um, a mix of both coming up. Of some people want to take a break, and some people want to continue. And I think this is a fine place to break. So let's take a half-hour break. I will see you back at 3:40 p.m. and we will pick up on platelet disorders. So 30-minute break. Okay, it is 3:40 p.m. Eastern time, so it is time to get started again. All right, everybody back. Disorders, just three main platelet disorders that we want to go through that you should be aware of and focus on. Primary immune thrombocytopenia, ITP. Characteristics are an autoimmune process of platelet destruction and decreased platelet production. Typically, this is diagnosed as a diagnosis of exclusion. Typically, patients have, you've worked them up for every other potential cause, so to speak, of some type of thrombocytopenia, and this is what is then ruled in, right? First line treatment are corticosteroids. And corticosteroids help to preserve current platelets as well as recruit new platelets. IVIG treatment, if you need a more rapid increase in platelets, we can do that. And anti-RHD is also treatment as well, IG, which will stop the autoimmune process. If they're actively bleeding, platelet transfusion with IVIG or anti-RHIG. Remember that when we transfuse platelets, just transfusing platelets because a number is low has very low utility, simply because transfused platelets have a half-life of 15 minutes. So unless they're being used up, they're going to die off before they get used. So it's not like it's really beneficial to just transfuse platelets. So we really reserve platelet transfusions in most cases for somebody who is actively bleeding. Sometimes in oncologic diagnoses, we see that a little bit different in that process. But for the general population, unless somebody is actively bleeding, just transfusing platelets to get the number up is not beneficial because they have a short half-life of 15 minutes, which means that they are going to die off before they're even used. Heparin-induced thrombocytopenia, also known as HIT. So heparin-induced thrombocytopenia, there's two types. There's type 1 and type 2. Type 1 is basically just a reaction to the heparin, right? It is just a typical kind of side effect. Think of type 1 reaction as a side effect. Usually begins earlier in the first 1 to 4 days after therapy begins. And remember that with heparin-induced thrombocytopenia, this can be caused by low molecular weight heparins as well as unfractionated heparins. And type 1 is usually just a direct effect of the heparin. Treatment would be considering discontinuing heparin and observe the patient. In some cases, you can continue the heparin and you can just keep them, modify the heparin dosage and stuff based on protocols and levels and stuff along those lines. Type 2 reactions, this is the one that we see as a problem, right? This is an immune-mediated response where heparin-induced antibodies bind to platelets and activate them, which then causes severe thrombocytopenia. Usually this is later in the course of therapy, onset of 4 to 10 days after therapy begins. However, it can occur within the first 24 hours of therapy if they've had heparin therapy before or if they've had a reaction to heparin before. In a type 2 reaction, you would also be looking at heparin antibodies, right? You can draw heparin-induced antibodies, and if they're positive, it's a type 2 reaction. And that's usually now how you would differentiate between the two. Heparin antibodies would be present in a type 2. Heparin antibodies would be absent in a type 1 reaction. And in a type 2 reaction, we always have to stop the heparin and use an alternative anticoagulation method, such as direct thrombin inhibitor, most commonly argatroban. Disseminated intravascular coagulation. DIC is resultant of large amounts of traumatized tissue that stimulate the release of thromboplastin and stimulate extrinsic clotting, which then uses up all the clotting factors. We see this commonly in trauma. Sepsis and pregnancy are the most common areas that we see this. You can also see this in malignancy as well. Clotting factors are then used up and depleted, causing lethal bleeding. It's diagnosed by looking at a fibrinogen degradation product, FDP. If that's increased, that rules in DIC. Treatment, just like most of everything else we talked about, we need to figure out what the underlying process is that caused this, treat that underlying process, and then therapy while the underlying process resolves. Fresh frozen plasma, cryoprecipitate, platelet transfusions for active bleeding, and in some cases, therapeutic heparin, believe it or not, will actually be, it sounds backwards, but it actually works to preserve clotting factors so that we can then use them efficiently. All right, just two questions on these. You are the AGA CMP on a medical service and managing a patient who has a deep vein thrombosis following abdominal surgery. Initially, place the patient on therapeutic low molecular weight heparin injections. 12 hours later, the platelet count is 25,000. Upon further investigation, the patient reports having a reaction to blood thinners in the past. You determine the patient still needs anticoagulation, right? So obviously, sometimes we find this out after the fact, right? We do our due diligence in the beginning to make sure we're doing safe everything, and then all of a sudden something happens like this, and then the patient's like, "Oh yeah, I did have some reaction to a blood thinner. I don't know what it was," right? So you discontinue the heparin and order what? Is it clopidogrel, argatroban, warfarin, or unfractionated heparin? And direct thrombin inhibitor would be argatroban. And question number 5, during your preoperative assessment of a patient having elective hernia repair, you discover a health history consistent with bleeding tendencies. Patient reports frequent bleeding gums while brushing and frequent bruising without remembering the injury. Which of the following interventions is not appropriate? A therapeutic dose of vitamin BK parenterally, preoperative hematology consult, coagulation studies, hepatic function panel. The only thing you really would not do here is they don't need a therapeutic dose of vitamin BK, right? That is not appropriate right now. I don't know that a preoperative hematology consult is 100% necessary, but it's definitely not inappropriate. Either our coagulation studies or hepatic function panel. Probably where you would start with this is figuring out, like doing a history and physical exam and trying to figure out what is happening and then make informed decisions from there. I mean, the gums are bleeding. For all we know, this person has gingivitis, right? They have gingivitis and they're brushing their gums and they're bleeding, right? That could be what the bleeding gums are from. Bruising without remembering the injury. They could be elderly and bumping into walls, or not elderly and bumping into walls. You don't know, but really doing a thorough history and physical examination will help you narrow down where you're going to go to next, and then be able to determine what are the next steps from there. Somebody has a question, should we worry about the 4T scoring for the exam? I don't believe so. What I would know about the 4T scoring, so 4T scoring is for heparin-induced thrombocytopenia. And what I would worry about is if they gave you maybe a number on the 4T scoring, what does that mean to you? Any of the scoring system like 4Ts, Wells criteria, TIMI scoring, NIH stroke scale scoring, any of those scoring systems, what I would say about all of them is I wouldn't try to memorize going into your exam, how do you calculate them? But if they were to give you a number like NIH stroke scale, if they were to say the NIH stroke scale was 20, or if they were to give you a Wells criteria of 5, or whatever it might be, what does that mean to you? What action do you take based on that? But I don't believe, I have not heard of or ever experienced the 4Ts being on the exam, but definitely something, clinically you should be aware of, but never really saw it on the exam. I hope that helps. Any other questions? You're welcome. Sorry, I had to quiet my dog down for a second. She, like, without fail, at least once every course will have to get herself involved in the course somehow. And of course, it looks like there is a truck that drove down my road and stopped at the house across the street. And how dare you come down my dog's street and not get her permission, right? That's just how the world of dogs works. So she's very upset that that truck went down the street. However, if they broke into my house and tried to murder me, as long as they gave her a treat and played with her, she'd be totally fine with that, right? You just can't drive down or walk down her street without her knowing and having her prior approval. Anyway, let's moving on to oncologic disorders. And oncologic disorders, we're going to focus on the lymphomas and we're going to focus on the leukemias. Two types of lymphoma, and let's compare them back and forth, right? Hodgkin's versus non-Hodgkin's lymphoma. Hodgkin's lymphoma is a localized single group chain of lymph nodes, usually in the cervical chain. Hodgkin's lymphoma affects multiple lymph nodes with extranodal involvement being very common. Presence of Reed-Sternberg cells in Hodgkin's lymphoma under microscope. B cell are going to be most common involvement with non-Hodgkin's lymphoma with some T cell lineage. Prevalence in Hodgkin's lymphoma is in young adulthood and over the age of 55. Hodgkin's occurs pretty evenly between children and adults. Hodgkin's lymphoma is more common in men. Non-Hodgkin's lymphoma is going to be more associated with HIV and autoimmune diseases. And while the Hodgkin's lymphoma is going to have more of an association with the Epstein-Barr virus. Both symptoms are going to be basically the same: low-grade fevers, night sweats, unexplained weight loss. And when they say night sweats, I never really appreciated night sweats until I had it was actually a colleague of mine who was diagnosed with one of the lymphomas. I forget which one. And when he said night sweats, he's like, I always thought night sweats like just waking up, like, for instance, me, I sleep very hot, as people would say. I even in the wintertime, like I start with blankets and I'm kicking them off in the middle of the night. I'm always warm at night. I'm like a human heater. And yeah, I will sweat from time to time. But he said, definitely that is not the night sweats that you experience. He said he woke up one night in the middle of the night, and this went on for a couple days in a row before he actually went to seek treatment because he figured something was going on. He like soaked through the entire bed. He said the one night him and his wife had to wake up 3 times to change the sheets. That's how much he was soaking through the bed. So that is what they refer to as night sweats. So that's lymphomas. Leukemias are broken down into 2 types: myelogenous leukemia and lymphocytic leukemia. And there's an acute and chronic form of each type. So let's look at the myelogenous leukemias first, the AMLs and the CML. So acute versus chronic. The AMLs involve the immature myeloid lineage cells in the marrow. The chronic form involves the pluripotent hematopoietic stem cells. AMLs mostly in adults. CML is rare in children and mostly occurs between the age of 20 to 50. AML has symptoms of anemia, spontaneous bleeding, petechiae, and ecchymosis. These are the ones that usually with folic acid deficiency, they might screen them, right? The CML is a more of an insidious onset of mild anemia symptoms and then splenomegaly. Presence of anemia, neutropenia, and thrombocytopenia on AML with greater than 30% myoblasts, and under smear, they're going to see OR rods. In CML, it's going to be a presence of leukocytosis. The white blood cells are greater than 50,000, typically asymptomatic until their white blood cells get greater than 200,000 to 1,000,000. That's when they usually start seeing symptomatology. And in there, we start to see an increase in eosinophils and basophils. With the lymphocytic leukemias, the acute lymphocytic leukemia, this involves immature B and or T cells in the marrow. This is the one that is most common that we see in children. CLL, the chronic form of that, involves immature B and or T cells in the lymph nodes and is more common in adults, especially elderly, right? So typically they see this in elderly. It's more common in men than in women. In AL, there's an acute onset of symptoms that related to depressed bone marrow function, bone function, and CNS manifestations, where CLL tends to be more asymptomatic, nonspecific symptoms, and they can also develop hepatosplenomegaly. In fact, most people with CLL will go undiagnosed for quite a long time unless they have regular screening. And with, usually this is typically diagnosed later in life, like in the 70s, 80s is where I've typically seen it. I had one patient years ago who had CLL, and he must have had it for a while. He was only in his 50s. But he came in, he was actually a husband of one of the nurses I worked with in the ER, and he came in remarkably sick. And on autopsy, he was found to have CLL. And he just came in and went downhill very quickly, but it was found that he had CLL. And obviously very progressed, like he probably had it for a good 10 to 15 years before he actually got symptomatic and died. But then his father, happened to be diagnosed with it, and his father was like 80. And his father happened to be diagnosed with it. A lot of people who are in that age range tend not to explore treatment options for CLL because it has a good, without treatment, about a 10-year survival rate without treatment. So if they're already 80, some people make the decision, I can at least live till 90, right? And how many of us are living till 90 and 100 anymore? Besides my grandmother who lived to almost 101, right? But, in general, the later it's diagnosed in life, the least likely they are to seek treatment for it. In ALL, there's presence of anemia and thrombocytopenia, variable white blood cells with greater than 30% lymphoblasts on smear. CLL, they're looking at lymphocytosis, usually greater than 50,000, or I'm sorry, greater than 5,000. And some patients, and about 20 to 30% of patients, they will have low platelets, and they also have on peripheral smear smudge cells. Okay, so just 2 questions on these things, and then we'll move on. Which of the following is not true with respect to chronic lymphocytic leukemia? The person with this condition is frequently asymptomatic. Well, we said that is true with chronic lymphocytic leukemia, so that does not answer the question. Is marked with the presence of the Philadelphia chromosome? Well, we didn't talk about the Philadelphia chromosome, so we'll move on from there and let's see. Results in isolated lymphocytosis. Yes, right? Isolated lymphocytosis in chronic lymphocytic leukemia, and is most common in the elderly. And that is true. So the only one that is not true here is that it's marked by the presence of the Philadelphia chromosome. Philadelphia chromosome is present in CML. If they just genetic look, it's CML, Philadelphia chromosome. I think it's like chromosome 9 and I think 22, they like break and they exchange parts and then they end up with a really small chromosome 22. But obviously there's a lot of testing that goes on to figure that out. Which of the following medications is most appropriate for preventing tumor lysis syndrome in a patient diagnosed with Hodgkin's lymphoma? Allopurinol, lisinopril, gabapentin, or hydroxychloroquine? The correct answer here is allopurinol. Allopurinol is a medication that they will give to most lymphoma patients to prevent tumor lysis syndrome because tumor lysis syndrome is a problem in lymphomas as they're going through treatments. The cells start to break down, the cells bust open, and as those cells bust open, they get massive electrolyte disturbances. Obviously, they can lead to renal failure. Major treatment is IV fluids to flush it all out and try to correct any electrolyte disturbances that need to be corrected and can be corrected pretty quickly. All right. So that is what we have here. Any questions? For some reason, chapter 4 does not want to open. Oh, there we go. All right, any questions before we move along? All right, I don't see anything in the Q&A box, so we are going to keep going. All right, we are on to chapter 4, which is pulmonary disorders. Pulmonary disorders in chapter 4. And that starts off on page 59 in your workbook. We have a lot to cover in pulmonary, right? Pulmonary and cardiovascular are 2 big topics, right? So we have a lot to cover in pulmonary. We're going to start off talking a little bit about pulmonary function testing, get everybody kind of on a baseline with pulmonary function testing, asthma, COPD, tuberculosis, pneumonia, acute respiratory distress syndrome, pneumothorax, hemothorax, pulmonary embolism, and pulmonary edema. Okay, so we have quite a number of topics to talk about here. Some obviously more in depth than others, but for the most part, a long list of topics. Just so that you're aware, what we're going to probably do is get partway through this chapter, and then we will save the remainder of the chapter for tomorrow, right? And that puts us at a good point of where we need to be to make sure we're respectful of everybody's time, right? So we can pick up where we left off, page 59, which is pulmonary disorders. And on page 60, we're going to talk starting about pulmonary function testing. All right, so pulmonary function testing. Everybody comes with a different experience with pulmonary function tests and a different knowledge base of pulmonary function testing, right? Everybody's pulmonary function testing knowledge is not equivalent because sometimes, if this is one of those things that if you really aren't looking at them on a regular basis and you're not focusing on them on a regular basis, you're probably not as inclined to remember the ins and outs of pulmonary function tests, right? Or maybe you learned about them somewhere along the line and you never had to use them at all, right? They never came into play in your world. So we're just going to talk very briefly about pulmonary function tests, and then we're going to apply it to when we talk mainly about COPD, we'll apply it more there, right? If you are familiar with pulmonary function tests, great. If you are not, what I want you to start with is the first three things on this list, right? First three things on this list, which is the FVC, the FEV1, and the FEV1 to FVC ratio. All right, so the first three rows on this list. If you can remember these three things, you're going to be able to get through anything on your exam related to pulmonary function testing. And you're also going to be able to really work well with your patients to figure it out, right? So let's talk about FVC first. FVC is the forced vital capacity, meaning it is the volume of gas that is forcefully expelled from the lungs after maximal inspiration. So if you think of how they do pulmonary function testing, right? They put them into this little machine, they close up the door in the machine, and they give them a little mouthpiece. They have them take the big deep breath in, and then they have them blow out as hard as they can. And as they're blowing out, they're screaming at them, blow, 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 and trying to get them to blow harder and harder into this mouthpiece, right? Until there's no more air left and they have nothing else to give, right? They've completely emptied their lungs. The total amount of air that they could put out in that entire process, right, from start to finish, the total amount of air that came out, that is your forced vital capacity, right? That is your forced vital capacity. Your FEV1 is the amount of air that came out within the first second of that maneuver. So with the first second of them putting that mouthpiece in their mouth and starting to blow, the amount of air that came out within the first second, that is the FEV1. It's the forced expiratory volume in 1 second, right? Now, the machine will also, you put certain demographics into the machine. Like you can say you have I want to say it's age, gender, and height. So like a 5'8", I don't know, 50-year-old female, right? This information goes into the machine, and the machine will predict a 50-year-old, I don't forget what I just said, a 50-year-old female, 5'8", whatever information I just gave you, should be able to do this, right? This is what they should be able to do, right? Typically. Now, it'll say, like, for instance, and I'm just making up these numbers just to make them easy for us to play with for a minute. Say it says that in the first second, they should be able to put out 3 liters of air, right? And we're going to look at this on a chart, so it's going to make a little bit more sense. But say they said, the machine says within the first second, we should expect them to put out 3 liters of air. And say they put out 3 liters of air, right? Then their FEV1 is 3 liters, right? Which is good. But what we also do is we do a percent predicted value. So we look at how much of what was predicted did they do, right? So if it predicted that they did 3 liters and they did 3 liters, their FEV1 percent predicted value is 100%, right? But let's say the machine predicted that they should do 3 liters and they only did 1.5 liters in that first second. Then the FEV1 percent predicted value is 50%, right? And that number is really important when we get to COPD, that percent predicted value. And then the FEV1 to FVC ratio compares how much air came out in the first second versus how much air came out in total, right? So you take the amount of air that came out in the first second, You divide it by the total amount of air, and you're going to get a percentage. And that percentage roughly should be greater than 70%, because greater than 70% of your air should come out in the first second of the maneuver, right? So that'll give you a percentage. It'll say, based on what the patient did, based on their FEC and their FEV1, out of their total amount of air, 85% of it came out within the first second. 60% of it came out within the first second, right? And we'll talk about how that comes into play in a minute. All right. Once you're familiar and more comfortable with those three things, then start adding in the rest of the stuff and playing with the rest of the stuff. And it'll help you with your diagnosis. But this is enough, at least, to get you started and get you focused. Okay. The pulmonary function test, the purpose of pulmonary function test is to identify obstructive and restrictive diseases of the lungs. Obstructive diseases are your COPD and asthma. And when you think obstructive disease, it's reduced airflow rate, right? So it's limitation of airflow. It's a limitation of flow out of air. Where restrictive disease is a limitation of volume, right? It limits lung expansion. And we see things like ARDS, pneumonia, bronchiolitis, pulmonary fibrosis, those types of things. Let's look at this on a chart and make some sense out of what we just talked about, okay? Let's look at, and we're going to be talking mainly about obstructive diseases here. So let's apply it to an obstructive disease. We're going to look at this chart, and we're going to look first at the black line, because that's a normal patient, right? And you can see on the horizontal axis is time, and on the vertical axis is liters, right? How much in liters do they put out? So they all start at 0, right? We have the patient, we have him sitting in the thing, we give him the little mouthpiece, and we start screaming at him, blow, 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 and they start blowing. And you can see that the black line, it starts going down, and they put out 1 liter, 2 liters, 3 liters. By the time they get to FEV1, they're a little over 4 liters, and they keep blowing, 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 and then they get to the end and they're done. So in 4 seconds, they put out a little over 5 liters, right? So let's look at the results. We know that if, like, in the first second of the maneuver, the FEV1, they put out 4.15 liters. And in total, the FEC, they put out 5.2 liters, right? So I divide the 4.15 into 5.2, and that's going to give me 0.8 or 80%. So telling me that 80% of their total amount of air came out within the first second, right? And that is good. That is showing normal lung function. We can also, do the FEV1 percent predicted value. We look at the machine, and the machine said, well, you know what? They were supposed to do 4.5 liters, and they put out 4.15. You figure out, okay, what is the percentage that they achieved, right? And that's the FEV1 percent predicted value. Now let's look at an obstructive disease like a COPD, right? They start at 0, and we start seeing blow, 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 and they're 1 liter, 2 liters. They get to the 1 second mark. They're just a little over 2 liters. They're blowing, they're blowing, they're blowing. Much longer amount of time, and you can see they put out a lot less air, right? So our COPD patient, obviously, it takes them longer to get that air out because of all the air trapping, right? And they can put less air out because obstructive disease is limitation of flow out, right? So they only put out 3.9, where we saw the healthy person put out about 5 liters. They only put out about 3.9 liters in total. And in the first second, 2.35 liters came out. So if I divide the 2.35 by the 3.9, we get 0.6 or 60%, which is indicative of obstructive disease and something like COPD, right? Now let's talk about this a little bit more as we talk about asthma and as we talk about COPD. So with asthma, there's a whole description here in asthma, and you're welcome to read it. I'm not going to read it to you. I want to point out the most important thing. The most important thing when you're thinking about asthmatic pathophysiology is that last word in that quoted sentence is inflammation. Inflammation that leads to bronchial hyperresponsiveness and airflow obstruction. If you remember nothing about asthma, remember the word inflammation, right? That is like the key pathophysiologic feature of asthma is underlying inflammation. The symptoms should be pretty obvious to you: recurrent cough, wheeze, shortness of breath, or chest tightness. Usually symptoms are going to worsen at night when cortisol levels are lower because it's what? It's a disease of inflammation. Cortisol drops at night. Inflammation is not well suppressed when cortisol is not present, right? Exercise, viral infections, air allergens, pulmonary irritants, right? Asthma is classified, has to be made with a diagnosis with pulmonary function testing, and it is classified by a partially reversible FEV1, right? So what happens is with pulmonary function testing, if somebody with asthma, they would have, an obstructive picture on the asthma, on the pulmonary function testing. You give them a short-acting beta-2 agonist, and we should see at least a 12 to 13% increase in their FEV1. If we see a greater than 12% increase in their FEV1 after a short-acting beta-2 agonist, that classifies it as asthma. It's still an obstructive disease, but it's classified as asthma because it's partially reversible. The goals of asthma therapy are to reduce impairment, reduce risk, and optimize their health and function. We are going to identify patients at high risk for exacerbations and death from asthma, readily assess the patient's knowledge and skills for self-management, including their device technique, right? Making sure they can use that device appropriately because not all people do. And it is semi-difficult for some people to use that with hand-eye coordination and stuff along those lines. Also making sure all patients have an asthma action plan that dictates based on their peak flow, which is a version of the FEV1, right? Based on their peak flow, they know that they fall into a green zone, a yellow zone, or a red zone. And in a green zone, they're okay. In a yellow zone, they might have to change up their meds a little bit. In a red zone, they need to seek medical attention, right? And it outlines for them exactly what they're supposed to do in each zone and depending on their symptoms. So every patient should have an asthma action plan and make sure we're assessing their education on that plan as well as their education on their therapy. Short-acting beta-2 agonist is the typical acute reliever for asthma. Controller for persistent asthma is inhaled corticosteroids, which is preferred. We'll talk about that in just a second. And step-up therapy if not well controlled. Here are the newest guidelines for asthma, and these make asthma so much nicer, right? The GINA guidelines came out just a couple years ago, and this is more of an outpatient treatment guideline. But these came out just a few years ago and just made this so much easier, eliminated all these charts and everything else that we had for asthma. Look at the preferred controller choice, right? So preferred relievers are what we call the SMART therapy, which is a low-dose ICS and formoterol, which is a long-acting beta-2 agonist, as needed, or a short-acting beta-2 agonist as needed. Most people are still going with the short-acting beta-2 agonist as needed, right? Step 1 to step 5, right? They step up and can step down this hill. Basically, what you need to take away from here is once they are diagnosed with asthma, every patient should be on, in step 1, a low-dose inhaled corticosteroid and formoterol combination as needed. Or if you're doing the short-acting beta-2 agonist as needed, then they could do just a low-dose ICS taken whenever they're doing their short-acting beta-2 agonist. Okay. Step 2 is the same dosage, right? Step 3 moves it from an as needed to a daily. Step 4 moves it to a medium dose ICS to a long-acting beta-2 agonist. And then step 5 is higher dose inhaled corticosteroid, long-acting beta-2 agonist, and then add-on therapies that should be referred to pulmonary, right? So what do we need to take away from here? We need to take away from that every patient from the beginning is put directly on an inhaled corticosteroid, right? And why are they put on an inhaled corticosteroid? Underlying pathophysiology of asthma is what? is inflammation. So the inhaled corticosteroid makes sense, right? As they move up, they're moving up the dosage of the inhaled corticosteroid, transitioning from formoterol to a long-acting beta-2 agonist, and they need to have something for reliever. Reliever medications are the low-dose ICS formoterol as needed, or the short-acting beta-2 adrenergic agonist, along with a low-dose ICS used every time they use the SAVA. Should immediately have access to rescue therapy for symptoms. And takeaway point, if they're using any of their rescue inhalers greater than 2 days a week, they need better control. They need more consistent reliever or controller medication, unless they are using it for exercise, right? Some people will have asthma and do a significant amount of exercise, and they will use it daily if they exercise daily, or they exercise 3 times a week, right? The recommendation is 15 minutes before they exercise, use their rescue inhaler, and then they exercise. So what you really want to ask them, how many times you use it for symptoms? And if it's greater than 2 days a week for symptoms, they need better control. Systemic corticosteroids, this is treatment of inflammation during an asthma flare. Prednisone 40 to 60 milligrams, about 3 to 10 days, averages from 5 to 7. Usually I've done the 40 milligrams for 5 days when I worked the hospitals group, and everything seemed fine with that. No therapeutic benefit, injectable versus oral product. Usually you just give an injectable because it's not safe to have them try to swallow pills, right? An inhaled corticosteroid. Theophylline. Theophylline is still out there, believe it or not, should only be prescribed by a pulmonary specialist and in very specific situations. Not going to go too much into theophylline because it is not used regularly. It is like the drug of last resort when nothing else works, right? Theophylline toxicity is a real thing, and it requires periodic monitoring of theophylline levels. It reacts with almost every medication known to man, right? Which makes it very useless in clinical for people that have other chronic diseases. And it reacts to so many different things. It's unbelievable. So multiple drug-to-drug interactions, and definitely requires periodic monitoring. What I would focus on is, what are the signs of toxicity? The major signs of toxicity are the first three that you see there: tremors, seizures, intractable ventricular dysrhythmias. Usually it starts with a fine tremor, and that's a sign of toxicity, but it can lead to seizures, intractable ventricular dysrhythmias. They can also have side effects of hypokalemia, hyperglycemia, and vomiting and abdominal pain. So keep your mind, be able to identify signs of theophylline toxicity. That's about as far as I would go with that if I were you. I don't think it's useful going any deeper than that, right? All right, asthma exacerbations. So asthma exacerbations, mild, moderate, severe, and life-threatening. So usually this is based off of peak flow. You could do pulmonary function tests, but that's not really reasonable in most cases. So peak flow is what they do it on. Now, peak flow is either based on their personal best, or if they don't know their personal best or can't communicate their personal best, there's little charts that show what their personal best should be. A mild asthma exacerbation is dyspnea only with activity. They're still 70% or better of their personal best on their peak flow. Home treatment appropriate, confirm they have an asthma action plan. And every scenario, you're confirming they have an asthma action plan, right? Moderate asthma exacerbation, dyspnea that interferes with or limits usual activity, 40 to 69% of their personal best on the peak flow. This one requires a provider evaluation. Short-acting inhaled beta-2 agonist, systemic corticosteroids, confirm asthma action plan. Severe dyspnea at rest, interferes with conversation, less than 40% of their personal best. They should be going to the emergency department, where with a moderate, they could probably go to their primary. With a severe, they should go to the emergency department. They will likely be hospitalized even just for observation, and same therapies, adjunctive therapies as needed. Life-threatening, they are too dyspneic to speak. They have profuse perspiration. These obviously require emergency department treatment, hospitalization with probable ICU admission, and then the same therapies. Warning signs of impending respiratory arrest, and this goes for asthma as well as non-asthma patients. Drowsiness or confusion, paradoxical thoracoabdominal movement, absence of wheezing, but they're still symptomatic. They're bradycardic, right? It shows they're decompensating. They should be tachycardic in an asthma exacerbation. Absence of pulsus paradoxus, which we really don't look for, and initial peak flow of less than 25% of their predicted S value. We're worried about impending respiratory arrest. You can see the changes that happen with oxygenation values from mild, moderate to severe. I wouldn't focus on these. These are just kind of FYI that you will see oxygenation start to decrease. But as I think we said in like one of the prequels, oxygenation is not going to be the first thing that decreases in an asthma exacerbation. First thing that's going to decrease is going to be their peak flow. That's why peak flow is what we remember. If their CO2 is greater than 42, if you feel the need to do ABGs and their CO2 is greater than 42, you could consider this as respiratory failure and prophylactically intubate them for respiratory failure, or not prophylactically, but intubate them for respiratory failure. All right, that's asthma in a nutshell. Any questions on asthma? Okay, moving on, page 64 with COPD. This is typically a preventable and treatable disease process with some extra pulmonary effects such as right-sided heart failure. Its pulmonary component is airflow limitation that is not fully reversible. So remember how we said, in asthma, their FEV1 would show, their pulmonary function test would show obstruction, right? But then if we gave them a short-acting beta-2 agonist, we would see partially reversible FEV1 greater than 12%. You wouldn't see that on COPD. If you gave them the short-acting beta-2 agonist, you would still see the obstruction. It would not reverse greater than 12%, right? And then, exacerbations and comorbidities is what we're worried about here for longevity. Chronic cough, chronic sputum production, activity intolerance, and typically symptoms are going to progress over time. Exacerbation is going to be defined as any event that requires the patient to change medication based on symptoms. COPD assessment. So COPD assessment, pulmonary function testing is required for diagnosis. The way that you confirm it is an FEV1 to FVC ratio less than 70% or less than 0.7 post-bronchodilators confirms the diagnosis. And then classification of their severity is going to be determined by their FEV1. And we'll talk about that in a moment. For certain patients, and I see this drawn a lot more now on patients in general, is alpha-1 antitrypsin deficiency. This is for patients who develop COPD under the age of 45, specifically white men who develop COPD under the age of 45 or have a strong family history of COPD. They could have an alpha-1 antitrypsin deficiency, so they will be screened for that. I believe in some cases there's also routine screening for people who have not been symptomatic because they can treat this earlier. Alpha-1 antitrypsin does a lot of things, but one of its goals is it protects and preserves the alveoli. So in the absence of alpha-1 antitrypsin, the alveoli break down a lot easier and a lot more quickly, and then people develop COPD at much younger ages. Goals of treatment are to relieve and reduce the impact of their symptoms, reduce risk of future and adverse health events, including exacerbations, and encourage the reduction of risk factors, such as making sure they're vaccinated against flu and pneumonia and all that fun stuff. All right, so how do we diagnose somebody with COPD? Well, step one in diagnosing somebody with COPD is spirometric classification, right? You can see changes consistent with COPD on a chest X-ray, but you can't diagnose it with a chest X-ray alone. Because one of the things you'll see on chest X-ray that are significant for COPD is a barrel chest, right? Well, barrel chests happen as we age. So most elderly people will also have a barrel chest on X-ray. Doesn't mean that they have COPD. It's just a consequence of breathing for 80 years, right? The chest starts to reshape to make it easier for the patient to breathe. So that is a normal consequence of aging. you need to see pulmonary function tests to diagnose COPD. And the way that we diagnose COPD to make the diagnosis is we look at the FEV1 to FVC ratio. If it's less than 70%, you've made the diagnosis, right? Less than 70%, meaning less than 70% of the air that came out in 1 second, or less than 70% of their air came out in 1 second, right? So that makes diagnosis. Severity is on the percent predicted value. So remember we said FEV1, we'll see how they do, but the machine will also say they should do this, and then we compare it to what they actually did. And based on the FEV1 percent predicted value, they end up in a GOLD criteria. Now, some sources will list this as GOLD 1, 2, 3, 4. Some will list it as GOLD A, B, C, D. It doesn't matter. It's the same thing. 1, 2, 3, 4, A, B, C, D, right? It's all the same thing. You get the idea, right? And it is classified from anywhere from mild disease to very severe disease. And it's all based on FEV1 percent predicted value. So we made the diagnosis with the FEV1 to FVC ratio. Then we use the FEV1 percent predicted value to determine are they GOLD 1, 2, 3, 4, or GOLD A, B, C, D, right? If they're greater than 80% of their percent predicted value, they're GOLD 1, 50 to 79%, they're GOLD 2, 30 to 49%, they're GOLD 3, and less than 30%, they're GOLD 4, right? So we made the diagnosis and then we put them into GOLD 1, 2, 3, or 4. Then we look at their exacerbation risk, right? Their exacerbation risk, have they had any exacerbations or anything that mimics a COPD exacerbation within the last year? Or have they, or two or more of those, or have they had one or more exacerbations that cause hospitalization in the last year, right? That would determine if they're a higher risk for exacerbation and hospitalization. All right, so now we kind of put this all together. We made the diagnosis, we put them in a GOLD category, and now we're going to put them into a patient group. And the patient groups are A, B, C, D as well, right? So spirometric classification based on their FEV1 percent predicted value, they're either GOLD 1, 2, 3, or 4. We figure out what their hospitalizations are, and then we use the COPD assessment test, which is the CAP test, or the MMRC to do a symptom inventory. And the symptom inventory, the goal is to be as low as possible on these scales, right? The higher their number, the more symptoms they have, right? So we have here GOLD 1. So we put this all together, and based on where all these results fall, they fall into patient group A, B, C, or D. Group A is lower risk for exacerbation, less symptoms. Group B is still low risk for exacerbation, but has more symptoms. Group C has high risk for exacerbation, but less symptoms. And Group D has high risk for exacerbation, but has more symptoms. Okay. Now, what happens if, let's say, they're in spirometric classification GOLD 2, they've had no hospitalizations or exacerbations in the last year, right? So that we know now that it's, if we did that, it'd be group A or B, right? And then their CAT score is 10. Well, then they fall into group B. But what happens if their GOLD 2, their CAT is 10, but they had an exacerbation or they're hospitalized for their COPD? The GOLD criteria and the CAT score fall into group B, but the hospitalization falls into C or D. So you would bump them up to a group C, if that makes sense. And then based on those groups, now I wouldn't worry about trying to memorize how to put this all together. Just understand the concepts behind how do you get to group A, group B, group C, to group D. How's this all put together, right? Group A treatment, short-acting or long-acting bronchodilator is what is going to be recommended. It's a short-acting or long-acting bronchodilator. And you have three options: a short-acting beta-2 agonist, a long-acting muscarinic antagonist, or a long-acting beta-2 agonist. Take your pick for that patient population. When they hit group B, forget the short-acting. They're just going to a long-acting bronchodilator, which is the long-acting muscarinic antagonist or the long-acting beta-2 agonist. The guidelines, the GOLD guidelines do not stipulate this 100% anymore, but historically, the muscarinic antagonists is what have been recommended, right? So group A, that you can choose between a short-acting or long-acting bronchodilator. Group B, they need a long-acting bronchodilator. Group C, the long-acting muscarinic antagonist, and we should consider adding on a long-acting beta agonist. So whatever they were on in Group B, Group C moves up to that long-acting muscarinic antagonist. And then Group D is a combo of the long-acting muscarinic antagonist and the long-acting beta agonist. And this is where you can consider inhaled corticosteroids. Now, remember, the inhaled corticosteroids in asthma, they happen right away because of the underlying pathophysiology of asthma, right? The underlying pathophysiology of asthma is what? Is inflammation. So inhaled corticosteroids happen right away. COPD, the underlying problem is not inflammation, right? So we don't put them on inhaled corticosteroids right away. And in fact, there's studies that show if you put them on inhaled corticosteroids too early, it can actually lead to further exacerbations and complications. All right, so how about when they come in to see us, and what are indications for admission? Indications for admission are going to be very vague and non-specific, right? They're kind of like you're needing to make your own decision, right? Marked increase in intensity of symptoms, obviously if they're an acute respiratory failure, onset of any new physical signs that weren't in there before, if they failed to respond to initial medicinal management, so they tried to be treated as an outpatient and it failed, presence of serious comorbidities such as something like heart failure, or if they have insufficient home support to be able to manage themselves at home, right? Failure to respond to additional medicinal management is probably the clearest on the list. And most COPD exacerbations can be treated and will be treated as an outpatient. We just usually see the ones in the hospital that either failed outpatient treatment or they waited too long to do outpatient treatment. If they get admitted, then we have to determine, do they go to the floor, do they go to ICU, where are they going? Severe dyspnea not responding to initial therapy would be indication for ICU admission, change in mental status, worsening hypoxemia with PaO2 less than 40, worsening acidosis with a pH of less than 7.25. Remember, they should be in a fully compensated respiratory acidosis, so their pH should be normal. If they require invasive mechanical ventilation or have hemodynamic instability. Indications for non-invasive mechanical ventilation, basically BiPAP. The whole purpose of BiPAP is to prevent them from being intubated, right? Because once you intubate a COPDer, it's a toss-up whether we're going to get them off that vent or not, right? If they move from a compensated respiratory acidosis to an uncompensated respiratory acidosis, severe dyspnea with signs of respiratory muscle fatigue, or worsening hypoxia, NIMV would be appropriate to try to turn them around and prevent invasive mechanical ventilation. Invasive mechanical ventilation in COPD populations should be reserved for those who are unable to tolerate or fail NIMV therapy, who have suffered respiratory or cardiac arrest, decreasing level of consciousness, or aspirating, vomiting, inability to remove secretions. It wouldn't be safe to put them on non-invasive mechanical ventilation. Unresponsive hemodynamic instability, ventricular, supraventricular dysrhythmias, or have failed NIMV by worsening hypoxemia. ABGs, when we're looking at ABGs, a PaO2 of less than 40 indicates hypoxic respiratory failure in your COPD population. Hypercarbic respiratory failure would be somebody who has a CO2 greater than 45, which we would expect in a COPD, right? That their CO2s are going to be higher than normal. But if they have a higher than normal CO2 with a lower pH, less than 7.35, that indicates hypercardiac respiratory failure. Chest X-ray to exclude other pulmonary diagnoses, ECG to rule out any dysrhythmias, CBC and chemistries to rule out any blood disorders, polycythemia, anemia, bleeding, identifying any electrolyte abnormalities. Sputum assessment is really not routinely done anymore. You could consider cultures, but in order to get cultures, you really need a BAL. And they're not easy to get. They're annoying for the patient. They're painful for the patient. And there's not a lot of utility in sputum assessment. And the more and more that comes out, like you get that sputum assessment back, and usually there's not much to be done with it. But if where you work, if they do sputum assessments on a regular basis, I mean, good for them. Leave it for that. Oxygen titrating hypoxemia or titrate to improve their hypoxemia. Their target saturation should be anywhere between 88 and 92%. Bronchodilators, short tube beta agonists during an exacerbation or first line, and you can add on short-acting anticholinergics as well. Systemic corticosteroids, 40 milligrams, 5 days, usually is good for prednisone. Antibiotics do not need to be used routinely in COPD patients, but obviously would be considered if there's increased dyspnea, increased sputum volume from their baseline, or increased sputum purulence, or there's like a chest x-ray that's showing like, oh, they have a pneumonia going along with this or something along those lines, right? All right, any questions there? All right, not seeing anything. Just gonna get a drink because my throat is dry now. All right, no questions. I don't see anything, so we are going to move on. Question number 1 of the chapter, page 67. You're called to the emergency department to admit a 48-year-old male for asthma exacerbation. Patient's vital signs are as follows. Heart rate is 45, respiratory rate is 24, blood pressure is 96/45, pulse ox is 87% on 4 liters of oxygen via a nasal cannula. Peak flow on arrival was 40% of the predicted value. Patient is on continuous albuterol nebulizers and was given a dose of methylprednisolone or salmeterol, 125 milligrams IV. ABG was just resulted and reveals the following: a pH of 7.3, a CO2 of 50, a bicarb of 30, and a PO2 of 55%. Or not bicarb, HCO3. Yeah, bicarb. What am I doing? My brain, I think, has shut off. It's not reading those letters correctly. So let's go through that again. 7.3 pH, CO2 of 50, bicarb of 30, PO2 of 55%. Okay, now we're clear. Patient appears drowsy with confused conversation, is unable to speak more than a few words during your evaluation. You also note that the patient appears severely short of breath. However, there is no audible or auscultated wheezing. What is your priority intervention? Order additional dose of methylprednisolone, order a dose of lorazepam, intubate the patient, or increase oxygen to high flow therapy. So we have somebody here for an asthma exacerbation. They're on continuous nebulizers. They were given methylprednisolone. There's no reason for another dose, so we can get rid of that. The lorazepam, I don't know what we're going to do with the lorazepam, but we don't want them to relax even more than they already are, right? That's going to be problematic. But then we look at them, their pulse ox is 87%. They're on 4 liters, right? Their ABG with that pH of 7.3, CO2 of 50, and the bicarb of 30. I mean, they are in a hypercarbic respiratory failure, right? They're in a respiratory acidosis, and their PO2 is 55, right? So they're in a respiratory acidosis. They're drowsy. They can't speak more than a few words. They have severe short of breath. And even though they're that symptomatic, there's no audible or auscultated wheezing. It's pretty clear at this point what we need to do. We need to intubate them, right? We need to protect their airway. Right, I think and they're bradycardic. I've given you every possible reason to intubate them, right? Question number 2. While admitting a 30-year-old female patient for an asthma exacerbation, you discover that the patient has been in the emergency department 7 times in the past 2 months for asthma-related symptoms. She also reports shortness of breath 3 to 4 times per week that she is able to manage at home. She's only currently on albuterol Proventil inhaler. Which of the following medications would you add on for this patient? All right, so somebody just put her on a albuterol PRN inhaler, right? Which is probably fine based on, but now she's been in the emergency department 7 times in the past 2 months, and she's getting short of breath 3 to 4 times per week. So it's no longer a good idea, right? What do we need to add on, right? We need to add on the inhaled corticosteroid, right? Probably the inhaled corticosteroid and the formoterol combination is what would be required here. But at minimum, we need to add on to therapy an inhaled corticosteroid. Question number 3. The typical radiographic appearance of emphysema includes what? The presence of Curly's lines, redistribution of flow in the pulmonary vasculature, flattened diaphragm and increased retrosternal airspace, or whitening of terminal airspaces. And the correct answer here would be a flattened diaphragm and increased retrosternal airspace. That is appearance that is consistent with emphysema. The presence of Curly's lines, specifically Curly's B lines, is heart failure exacerbation. Redistribution of flow in the pulmonary vasculature is chronic heart failure. And whitening of the terminal air spaces, that is ARDS, right? Acute respiratory distress syndrome. Question 4. Which of the following would be indicators for starting antimicrobial therapy in a patient with a COPD exacerbation? Select all that apply. Would it be an elderly patient with no comorbidities? No. Would it be a patient on mechanical ventilation? Yes. A patient with increased purulent sputum production? Well, yep. Patient being discharged with poor follow-up? No. A patient with consolidation noted on a chest X-ray? Yes. B, C, and E are the patients that would get antibiotics or most qualify for antibiotics. Question number 5. You are admitting a 60-year-old male for COPD exacerbation. The patient arrived in the emergency department with severe dyspnea. After being on a short-acting beta-2 agonist and receiving intravenous corticosteroids, there was no improvement in symptoms. The ED provider placed the patient on non-invasive mechanical ventilation. ABG resulted as follows: a pH of 7.2, a CO2 of 50, a bicarb of 27, and a PaO2 of 35 on 2 liters of oxygen via nasal cannula. While evaluating the patient, you note that after 45 minutes of non-invasive mechanical ventilation, he is still symptomatic and unable to stay awake during your assessment. What's your next course of action? Well, again, I think the answer there is to intubate I know the answer there is to intubate the patient and admit to the ICU, right? He's failing therapy. He already is in an uncompensated respiratory acidosis. He's hypoxic. He's hypercarbic. There's a lot of problems going on, right? And now is unable to stay awake, is becoming drowsy. At this point, we can say he failed NIMV. He needs to be intubated, right? Starting him on an inhaled corticosteroid is not going to do anything. Repeating the ABG is one of those answers that I'm going to just sit there and watch the patient decompensate, right? That's it for that. Any questions there? What type of antibiotics are given in pneumonia for COPD? We'll get to that in pneumonia. Really, you're treating them with any of the antibiotics appropriate for pneumonia, but we'll get to pneumonia antibiotics in just a few moments, actually. So hang in there with that one. All right, any other questions? Go back to question 4 on responses. The correct answer to question 4 is B, C, and E. You're welcome. All right, let's talk about tuberculosis. I really don't have much to say about tuberculosis, but we'll talk a little bit about it. Right, tuberculosis. We know that tuberculosis actually can end up anywhere in the body, but we're most commonly familiar with it in the lungs, right? The causative organism is a rod-shaped, non-spore-forming aerobic bacterium known as Mycobacterium tuberculosis. Active versus latent TB. Active TB is infection. Patient is infected with tuberculosis, has positive sputum cultures, positive findings on a chest X-ray, and active symptoms of TB. And you can see all the symptoms listed out there for you, right? Latent TB, they were screened for TB with a known direct, what's it called? Like a known direct insult, a known direct exposure is the word that I'm looking for to tuberculosis. They have positive screening. Their chest X-ray is negative. In the sputum, it's negative. They may see the bacteria, but they're inactive, and they tend to be asymptomatic, right? Who are candidates for TB testing? Anybody who's spent time with a person known to or have suspected of having TB disease, people who have HIV infection or another condition that makes them immunocompromised, patients who have symptoms of active TB, obviously, patients from a country where TB disease is most common. You can see some of them listed out there. Patients who live in the US where active TB disease is more common. Same as like your MRSA type patients, like homeless shelters, migrant farm camps, prisons, jails, nursing homes, those group living facilities, patients who inject legal drugs. TB, PPD is still widely used along with some blood testing options now, like IGRAs and stuff like that. You should be familiar. I'm not going to read this all to you, but basically, in the general population, greater than or equal to 15 millimeter duration is what's positive. Patients who are at high risk for exposure, such as us who work in healthcare facilities and stuff like that, 10 or better. Patients who are immunocompromised, 5 or better in duration is considered a positive. Active tuberculosis versus latent tuberculosis treatment. I really don't have much to say about this, and I don't want to I just want you to be aware of what's there. Know that for active tuberculosis, there is a multitude of different agents, INH, rifampin, ethambutol, pyrazimide, that they are on a treatment regimen for 6 to 12 months. And there's multiple ways they could be taking this, right? Infectious disease needs to be involved. The State Department will probably, Department of Health will probably be involved, and all of that fun stuff. You will not be doing this on your own at all, right? But just know it's going to be multi-drug regimen for active TB, 6 to 12 months of therapy. For latent TB, primary regimens are INH and rifampicin for 3 months or rifampin alone for 4 months. INH alone is an alternative regimen for 6 to 9 months. But again, you won't be treating this on your own, right? So just remember these concepts behind treatment. Remember with latent TB, the thing too is that a lot of times they will put these patients on direct observation therapy because latent TB can turn into active TB. And if the patient is not treated or is not compliant with their treatment, they can end up with a very highly drug-resistant version of TB, which obviously would not be good, right? So we would not want to see that happen. All right. And then, so that's TB. That's all I really have to say about that, just a few concepts. Pneumonia is the next one. And we're going to go through different concepts on pneumonia. And we'll actually see, we'll see where that brings us. All right, so for pneumonia, key concepts in pneumonia. Causative pathogens. I told you need to know your causative pathogens, right? S. pneumoniae is going to be your most common form. H. flu is very common in those who have tobacco-related lung disease or smoke. M. pneumoniae, C. pneumoniae are your atypicals that are more like your walking pneumonia. Staph aureus is very uncommon, but possible. Legionella is a very atypical. I think they used to say it was non-gram staining, but now I think they're finding gram-negative forms of Legionella. Legionella is very atypical from its presentation as well. Legionella, you get very sick from Legionella, but Legionella is not spread from person to person. Like if we were all together in a conference room and say I had pneumonia that was staph, H flu, or strep, H flu, M pneumoniae, C pneumoniae, I could spread that to you very easily, right? If I had Legionella pneumonia, I cannot spread it. It's not spread from person to person. It's spread from vaporized water. So usually Legionella grows in stagnant water, and then that water vaporizes, and that's how people get it. So that's what makes it so atypical. It was first discovered at the Legionnaires' Conference in Philadelphia, where they all got Legionella pneumonia from the ventilation system, right? There was in the ventilation system stagnant water. And then when the ventilation system turned on, it vaporized that water and they all got Legionella, right? Legionella was growing in there. I've also, this was years and years ago, and actually I don't even see these in grocery stores anymore, but and maybe you do where you are, but I haven't seen this in so long. Remember in grocery stores and the produce sections, they used to have they would spray all the vegetables, right? Because even though the vegetables were dead, right, and just waiting to be eaten, spraying them made them look pretty, right? It made them look more appetizing and all that fun stuff, right? And then you would get them home and they would rot faster because they were all wet if you didn't wipe them off and all that fun stuff before you put them away. There was an outbreak, and I forget where it was. I want to say in the Midwest somewhere. There was an outbreak of Legionella pneumonia. And they did something similar like what they did with COVID, like contact tracing, all that stuff. And with this outbreak, they contract traced it back to this one grocery store that everybody that was getting Legionella pneumonia was at. And apparently, what was happening was Legionella bacteria was growing inside the sprayers, like the piping for the sprayers. So every time the sprayers turned on, it was vaporizing that water, right, to spray the vegetables. And then it would vaporize Legionella into the air. And people walking down during that time and touching the vegetables and all that stuff would get Legionella pneumonia, and that's where it came from. It was the weirdest situation, but it definitely makes sense of how it was spread. So I guess the moral to the story is if your grocery store still has the sprayers, hold your breath as like you're picking up your zucchini and your lettuce and all that fun stuff, because who knows what's growing in those tubes, right? But again, very typical where Legionella would grow. IDSA ATS recommended workup for pneumonia should be CBC with white cell differential, BUN creatinine, chest x-ray looking for consolidation to make the diagnosis. And then based on obviously patient factors, you would do a different, or you might do additional testing. Treatment guidelines recommended length of therapy for community-acquired pneumonia is a minimum of 5 days, and they should be afebrile for 48 to 72 hours prior to stopping antibiotics. The IDSA and the ATS, so the American Thoracic Society and the Infectious Disease Society of America, make it really easy treatment-wise, right? If they have no significant comorbidities, so if they don't have COPD, they don't have diabetes, they don't have renal disease, they don't have heart failure, they don't have asplenia, they don't have alcoholism, most likely common pathogens are going to be strep, M. pneumoniae, C. pneumoniae, right? Can also be obviously viral in nature. But knowing that, the IDSA and the ATS recommend one of these here. They give you options to pick from. I will tell you the most common options are going to be the oral doxycycline or the azithromycin. Sometimes high dose amoxicillin, but doxycycline and azithromycin seem to be the most common. Clarithromycin and erythromycin can be used, but they have a lot of side effects and people don't tolerate them well. So usually doxy, azithromycin, oral amoxicillin, high dose, right? Those are for people with no significant comorbidities. If patients have significant comorbidities, so if they have COPD, they have diabetes, they have renal or heart failure, they have asplenia, they have alcoholism, really it can run the whole gamut of pathogens that they have. And the recommendation is either a respiratory fluoroquinolone, depending on resistance patterns in your area, a respiratory fluoroquinolone, or a mixture of the doxycycline or a macrolide plus a beta-lactam, right? So you can mix together, like, say, doxycycline and doxycycline, you could do clarithromycin and augmentin or something along those lines, right? So that's somebody who asked earlier about COPD. This is what you would follow, right? How do we know if patients with community-acquired pneumonia need to be admitted or should be admitted to the hospital? Well, we have to risk classify them, right? CURB 65 is still a criteria that's out there. I've changed in this course CURB 65 to the PSI port scoring system because this is what the guidelines tell us they want us using now. They say we could still use CURB 65, but they prefer PSI port scoring. So risk stratification, we have to classify these patients as either risk 1, 2, 3, 4, or 5, right? So where we start, and I don't want you to memorize this, I just put this here for you so that you understand it, so that you see it. I'll tell you the part that you need to know. But what you need to do is you need to look at their demographic factors and their history. If none of this on this screen applies to your patient, right? If none of this applies, if you can't say yes to any of this for your patient, they are class 1 automatically, and that's where you stop, right? You just stop there. If none of this applies to your patient, they're class 1, and you just stop. You don't have to further evaluate them for admission. If you look at them and there's at least one, like say they're 60 years old, or say their heart rate is 130, or say their temperature is 103.5, whatever, or they have heart failure, or they have a neoplastic disease, whatever. If they meet any one of these bullet points, if you can say yes for your patient at any one of these bullet points, they are then going to fall somewhere between class 2 and class 5, and you have to do a further risk assessment, right? So if none of this applies to them, they're class 1, don't worry about it. If even one of these things apply to them, they end up then needing further assessment for class 2 to class 5, right? This is the assessment that they do, right? This is what gives them points. Everybody gets points for all of this. The only people that get to take away some points is if you are female, you get to take away 10 points off your age. So if you are 35 years old and you met like one of those things and you were calculating your risk, your initial points are 35 minus 10, you're 25. But if you're a 35-year-old male, your points are still 35, right? So if you're female, you get to take 10 points off your score, which is actually a good thing because the less the score, the better, right? So then you go through all of these things, you add them up, and then we figure out based on the points, where did they fall? Now remember, on that first screening thing, like the risk stratification, screening, the demographic factors, and patient history, if they met none of those criteria, you don't need to score them on anything else. They're automatically class 1, they're outpatient treatment. If their PSI port score is less than 70 points, they're class 2, they can still outpatient treatment. 71 to 90 points is considered class 3, outpatient or inpatient treatment. This might be your perfect like 24-hour obs patient, right? 91 to 130 points, class 4, greater than 130 points is class 5. And then their inpatient treatment, you need to determine, are they going to a regular medical floor or do they have to go to like an ICU, right? This is what you should know. And this is what I talked about those scoring systems. If I were to give you a question that says your patient's PSI port score is 97 points, what does that mean to you? That means that I'm keeping them as an inpatient. I need to figure out if it's going to be ICU or not, right? General treatment is ceftriaxone 1 to 2 grams IV daily, or ceftaroline plus azithromycin. For more severe cases of CAP, you could do a beta-lactam plus a macrolide of your choice from the list that we talked about before, or a beta-lactam plus a fluoroquinolone from the list we talked about before. All right. Let's talk about hospital-acquired and ventilator-associated pneumonias. So hospital-acquired and ventilator-associated pneumonias, most common cause of hospital-acquired infections, they're 22 can be 22% of all hospital-acquired infections. Serious complications occur in 50% of patients with hospital-acquired pneumonia, 25 to 50% increased mortality in a patient who develops ventilator-associated pneumonia. Now, this is pneumonia that has developed more than 48 hours after admission. So if they come into the hospital and within the first 24 to 48 hours, they develop a pneumonia, they brought that in with them, right? If 72 hours or more after they've been in the hospital, they develop pneumonia, we gave it to them, right? So think about it that way. So likely pathogens. So remember, in order to be considered hospital-acquired or ventilator-associated pneumonia, right, it's more than 48 hours, right? So 72 hours or more, so 3 days or more in the hospital. So early onset hospital-acquired pneumonia, if they're in the hospital for less than 5 days and they develop hospital-acquired pneumonia, it's likely one of these things going on, right? As long as they don't have any other factor for drug resistance, they're likely one of the less drug-resistant pathogens. If it's later onset, if they develop this pneumonia 5 days or more after being in the hospital, they have a much higher risk of multi-drug resistance and things like MRSA and gram-negative enteric bacilli, such as Acinetobacter, Klebsiella, Seriata, Acinetobacter, Pseudomonas, right? So if they have a low risk of mortality and no factor that increases their likelihood of MRSA, you just choose one from this list. Take your pick. It doesn't really matter. Just choose one. If they have a risk of MRSA or a likely increased risk of MRSA, so any of those patients who are in like group homes, come from jails, antibiotics within the last 90 days, stuff along those lines, use any of your low risk options, plus you're going to add on IV Vanco or IV Linzolid. If they are severely ill, they have a higher risk of mortality, they've had IV therapy within the last 90 days, you're going to choose 2 of these, but avoid 2 beta-lactams. So you could do the piperacillin and the levo. You couldn't do the piperacillin tazobactam and the cefepime, right? Those are two beta-lactams. You don't want to put them together. But you're going to cover with the higher risk of mortality, or if they've had intravenous therapy within the last 90 days of antibiotics, you're covering for a wider array of pathogens, right? So any of these on this list, including amikacin, plus you're going to cover them for MRSA, which is going to be the Vanco IV. How do we determine duration of therapy for hospital-acquired pneumonia? Duration of therapy, we're back to looking at PCT, procalcitonin levels. Now, not every facility is doing this, and I understand that. These are based on the guidelines. The guidelines are telling us, procalcitonin, it was like huge when it first came out. We were watching procalcitonin, everybody got procalcitonin. Then it seemed to like disappear. Then it started to come back, then it disappeared. Now it's back in the guidelines. And what the IDSA guidelines tell us is that once procalcitonin levels drop less than 0.25, we should discontinue antibiotics. Ventilator-associated pneumonia, they are the same as hospital-acquired pneumonia with increased likelihood of Pseudomonas and MRSA. Assume that a patient who develops ventilator-associated pneumonia has Pseudomonas and assume they have MRSA with it. Just assume that. It just is what it is, right? They're most likely. So all of these are still possibilities based on the onset, but assume that MRSA and Pseudomonas is more likely. Now, these guidelines have been modified just a little bit, but I'll tell you that in most circumstances, these still work this three antibiotic algorithm, right? For ventilator-associated pneumonia, it's typically a 3-drug regimen. Antibiotic number 1 covers gram-positives and covers MRSA, right? So that's your Vanco and your Linzolid, right? That's what that is. That's antibiotic number 1. Antibiotic number 2 covers gram-negatives and Pseudomonas. And this is covering with a beta-lactam, right? So antibiotic 1, you covered gram-positives and MRSA. Antibiotic number 2 is beta-lactams that cover gram-negatives and Pseudomonas. And then antibiotic number 3 is a non-beta-lactam with gram-negative and Pseudomonal activity, right? So you're covering gram-positives and MRSA, and then you're covering gram-negatives and Pseudomonas with a beta-lactam and a non-beta-lactam. Now, you might see this done very differently where you work, and that is okay, and that is like, some people just do like maybe cefepime and vancomycin or something like it, and that's totally fine. This is what I would follow for your exam. Again, more importantly than knowing how to treat this is really understanding how do we prevent this from happening? Well, the way that we prevent ventilator-associated pneumonia is number 1, to prevent intubation altogether, right? If we don't intubate the patient, they can't get ventilator-associated pneumonia. So prevent intubation, good hand hygiene of clinicians and providers, good patient oral care if they're intubated, elevate their head of bed 30 to 50 degrees when they're able to. Duration of antibiotic therapy, again, same thing with the procalcitonin levels. And then some other inhaled recommendations that I would really not focus on for the purposes of your exam. All right, any questions there? All right, you guys are going way too easy on me here. So feel free if you have questions, throw them out there. All right. Question number 6, which of the following methods are proven to prevent ventilator-associated pneumonia? Select all that apply. So never pick all, never pick just one. Prophylactic systematic antibiotics for all intubated patients. Well, no, that is not proven. Non-invasive mechanical ventilation. Yes, because it prevents intubation, right? So letter B is yes. Regular use of oral antiseptic agents. Yep. Elevating the head of the bed to 25 degrees. No, it should be 30 to 45 degrees when able. Good hand hygiene? Yes. So far B, C, and E are correct. Trending procalcitonin levels. Now, that doesn't prevent ventilator-associated pneumonia. That determines when we stop antibiotic therapy. So B, C, and E are your correct answers there. When determining the duration of antimicrobial therapy, for hospital-acquired pneumonia, which of the following is the most accurate indicator of discontinuing antibiotics? Is it return of the patient's core temperature to normal, decreasing leukocytosis, procalcitonin level of less than or equal to 0.25, or a clinical pulmonary infection score of 11 points? Correct answer is the procalcitonin levels. We talked about those, right? Right? We talked about those. Of course, we want their temperature to normal. Of course, we want to see decreasing leukocytosis, but the procalcitonin level less than or equal to 0.25. Again, you may or may not be doing that in your facility, and I understand. I honestly, we don't do it where I work either. But this is what they are recommending. But we haven't really, I see it once in a while, but not consistently. Clinical pulmonary infection score was a scoring scale used to determine when you stopped antibiotics in pneumonia a couple years ago, and they no longer recommend that in the guidelines. Which of the following signs or symptoms would be the earliest indication of pneumonia in the elderly population? Is it shortness of breath, confusion, fever, or hypoxia? Well, really any infection in the elderly population, what is the first sign? Usually confusion, right? Usually confusion. They get confused. That is the first sign of infection in that population. All right. So I am just looking through here. All right. Again, we're not getting a ton of questions, which is not a bad thing as long as you don't have questions. So we're a little bit ahead of time. Usually I would save acute respiratory distress syndrome until tomorrow. But I kind of feel like it's early. I don't want to end this early, so I think we should keep going. What would you rather do? Would you rather talk about acute respiratory distress syndrome? Or would you rather skip that? We'll do that tomorrow, and we'll talk about like pneumothorax, hemothorax, pulmonary embolism, and pulmonary effusion now. Or do you not care? Like, if you're not familiar with ARDS, I don't want to like pepper you with a ton of information at the end of the day. Like, we will definitely go back. We're not going to skip it completely and never revisit it again, right? Some people don't care. All right, so some people are saying let's skip our, so we're going to skip forward in our book a little bit, right? Because if you're not familiar with ARDS, there's probably this is where we tend to get some questions and some things that we want to make sure we go over. So we're going to skip over to page 79. Just remind me when I start tomorrow, just in case I forget that we're starting with talking about ARDS, and we're not, starting and we're going to repeat all of this other stuff, right? All right. So let's talk about pneumothorax, hemothorax. We'll talk about pulmonary embolism. We'll talk about pleural effusion. We'll see how far we get, honestly. Pneumothorax and hemothorax, very straightforward, right? Pneumothorax is increased gas in the pleural space from a variety of factors, usually from traumatic injury, can also be from COPD or asthma from developing blebs on the lungs, can be from marijuana smoking from developing blebs on the lungs that burst and then cause air to get trapped in the pleural lining, right, in the pleural space. It can also be more spontaneous from Marfan syndrome, which is a growth hormone disorder that causes their lungs to be very weak and they can just rupture the lung lining, causing a pneumothorax, right? But probably the most common place that we see this is in traumatic injury, obviously. And usually it is from blunt force trauma, but it can be from penetrating trauma as well. If the air gets trapped, so if you think about a pneumothorax, the lung lining, the pleural lining has a hole in it, right? And air has escaped and got into that pleural space. And as the patient breathes, there's like a trade-off between the pleural space and inside the lung, the pleural space inside the lung, right? If the air were to get trapped outside the lung and it can't get back in, and it keeps building up, building up, building up, that is what we call a tension pneumothorax that will put compression of the great vessels, the heart, cause obstructive shock and needs immediate treatment. Chest X-ray is the diagnostic study of choice. You'll see air in the pleural space with the absence of lung markings going out to the outside of the chest wall. Sometimes you will see people get a CT scan just to evaluate if there's anything else that they're missing or really how big this is, but usually just a chest X-ray gives you enough. I mean, there has been once or twice where, we got a chest X-ray that looks like just a small little pneumothorax, and then they went for a CT scan of the chest because it's trauma, and you end up with a CT scan of the chest. And you look at the CT scan, you're like, holy crap, that does not match the chest X-ray, right? It's a lot bigger than anticipated. Signs and symptoms. Know your percussion notes for the lung fields, right? Resonance is normal. Hyperresonance is air trapping. Dullness is over fluid or some type of cellular buildup, right? So hyperresonance to percussion, acute onset of shortness of breath, tachypnea. These are the typical signs and symptoms that you're going to see with a pneumothorax. Tension pneumothorax, they get more severe respiratory distress, signs of obstructive shock, hypotensive, distended neck veins, which is a much later sign of tension pneumothorax, and a tracheal deviation where the trachea moves away from the area of injury, from the side. So if they have a tension pneumothorax on the right side of the chest, their trachea will deviate all the way to the left because of all that pressure pushing it over. Needle decompression is first-line therapy for primary pneumothoraces or small secondary pneumothoraces in patients who are minimally symptomatic. So sometimes they can just do a fine needle decompression. Usually they're doing that in like IR. But most cases, at least in my world, most people are getting chest tubes, or if they don't need a chest tube, we're not even doing the fine needle decompression anymore. We're just kind of watching and waiting and keeping an eye on it, repeating chest X-rays and making sure, monitoring symptoms, stuff along those lines. Chest tube placement is going to be the definitive treatment of choice for most patients, especially those with larger pneumothoraces. Most chest tubes now for pneumothorax are going to be pigtail chest tubes versus like the huge regular size chest tubes. So we're doing a lot more pigtail chest tubes than we are the large bore chest tubes that we're used to in the past, which is nicer for the patient. Tension pneumothorax, emergent needle decompression if you don't have chest tube immediately available. 14 to 16 gauge IV, second intercostal space, jam it into that space. Careful that needle will fly off, air will escape, but they will eventually need chest tube placement. Obviously, if they have chest tube readily available, get the chest tube in quickly. Hemothorax is blood accumulation in the pleural space, typically caused by some form of traumatic injury. Usually penetrating trauma is most common for hemothorax, but it could be by blunt trauma as well. Also can be caused by an injury from adjacent structures such as costal blood vessels, great vessels, liver lax, spleen lax, diaphragmatic injuries, stuff like that, where blood's going to leak up. Chest X-ray is the diagnostic study of choice. So we see blood in the pleural space, a complete whiteout. Signs and symptoms, dullness to percussion for this one, dyspnea, tachypnea, decreased breath sounds in the injured sign, and in some severe cases, signs of hypovolemic shock. Chest tube placement is what's needed, and this is a regular sized chest tube. A pigtail will not do it for this, right? Open thoracotomy in the presence of uncontrolled bleeding, or even a video-assisted thoracotomy, but usually open thoracotomy if there's uncontrolled bleeding and it's not getting controlled. Can also consider autotransfusion in very severe cases where patients are losing large amounts of blood, as long as it is a closed chest injury, right? If it's a penetrating chest injury, you can't do autotransfusion. It has to be a closed chest injury. And if they're losing a lot of blood into that container, into the pleurovac, you can do autotransfusion. Probably will lead them to an open thoracotomy at some point, but at least it's helping them in the meantime. What autotransfusion does, if you're not familiar with it, so the pleurovac, you can get an autotransfuser which attaches to the side of the pleurovac. You put an anticoagulant inside of the autotransfuser, and as long as it's a closed chest injury, what will happen is then the blood will collect into the autotransfuser, and you can then, once it's full, spike the autotransfuser at blood tubing, turn it upside down, and give the blood back to the patient, right? That's like very severe cases and probably not used very often. Definitely not used often in a trauma center, like where I work, but that could more often be used in maybe a smaller emergency department that doesn't have trauma capabilities as they're waiting to get them to trauma, right? All right, pulmonary embolism. So we know that pulmonary embolism, remember, is not a ventilation problem. It is a perfusion problem. So pulmonary embolism is a perfusion, not a ventilation problem. Keep that in mind. Most commonly caused by thromboembolism from a DVT. So the most common cause is a DVT. Also seen in patient with oncologic diagnoses, where we see usually multiple micro PEs, where DVT, we usually see one whopping PE. Tons of signs and symptoms here to look at. If I had to narrow these down, I would do sudden abrupt onset of dyspnea, pleuritic chest pain, tachycardia, tachypnea. Remember those four: dyspnea, pleuritic chest pain, tachycardia, tachypnea. CTA of the chest is diagnostic study of choice. That is basically what everybody's using now. Very rarely, I don't know, you guys can throw it in there if you guys are using these, but I don't even see them used anymore, is VQ scans. VQ scans are nuclear medicine scans that were utilized for patients who could not accept diload from the CTA. But they have very utility. They come up with a either high probability, what is it, intermediate probability and low probability for PE. And 99% of patients came back with an intermediate probability. And an intermediate, high probability means yes, they most likely have a PE. Low probability means probably not. And intermediate probability is like, we don't know. They might not. So you were no better off, after and you just treated them, based on whatever. But VQ scans are not really used as much anymore. CTA is really the diagnostic study. You still do see them pretty often. Yeah, I can't. I have not. I have not seen a VQ scan in years. Or at least if I have, I haven't ordered one in years. I can't remember the last time I ordered one. I want to say it was like the early 2000s. But yeah, they were used for people with poor kidney function or, for whatever other reason could not get a CTA. So anyway, laboratory assessment screening, the D dimer has high sensitivity but poor specificity, meaning if your D dimer is negative, less than 500, it rules out PE. If it's positive, it has poor specificity, so we don't know what it is. So then we have to we have to do a confirmatory of CTA. D-dimers, I think, may still be used pretty regularly in like an ER situation, but in hospital, we rarely, at least in our practice, we rarely use D-dimers anymore. If I suspect somebody has a PE, I send them down for CT because likely their D-dimer is going to be positive because of surgery and everything else that they went through, right? So they're not as useful, at least in my practice. Wells criteria, know the scoring. If I gave you a Wells criteria number, what would that mean to you, right? We talked about that. Um, what else? Moving on to treatment. Anticoagulations, the duration is going to be dependent on the cause. And remember, duration, once you start them on anticoagulation, you're treating them for pulmonary embolism or you're treating them for DVT or something along those lines. When you're thinking about continued care, remember that their primary care is going to be the most important person in their life to continue all of this care, right? They are going to be the ones that are going to coordinate everything. They're going to be the ones that are going to follow up with them. So making sure they have a good relationship with a primary care provider. Unfractionated low molecular weight heparin in the hospital, obviously. Warfarin with an IR goal of 2 to 3, really not used very often anymore, but still an option. And now more commonly, the direct oral anticoagulants. But usually in the beginning when they are first, as long as they can handle unfractionated heparin, usually in the beginning with a P, they're going to be doing unfractionated heparin. IVC filters, if anticoagulation is contraindicated. Thrombectomies, large proximal PE with hemodynamic compromise. Thrombolysis if they have signs of hemodynamic shock. All right, any questions there? And if not, we will move on to pulmonary effusion. And what I'll probably do is we'll talk about pulmonary effusion, and then I will probably we'll start off tomorrow. I'll save the questions for tomorrow because I don't know if there's any questions at the end. I don't think there are. I'm looking through real quick. I don't know if there are any that would benefit from our ARDS conversation. I don't think they would, but all right. So pulmonary pleural effusion, transudative versus exudative effusions, right? Transudate infusions, congestive heart failure. So think of transudates as water, right? Think of it as free water. Think of exudates as cellular material. Oh, I'm sorry. I totally missed. There's a couple questions. Signs would be obstructive shock, right? For PE, yes. Yep, looking for obstructive shock signs, absolutely, for thrombolysis. D-dimer, remember from class about a long flow chart about what to do. What I would remember there's a couple different pieces of literature out there that give you this whole flow chart of if the D-dimer is positive, D-dimer is negative, blah, 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 and going through this whole process. What I would remember as far as your boards, and even for clinical practice utility, quite honestly, if the D-dimer is negative, you've effectively ruled out a PE, right? Or even a DVT, but you effectively ruled out a PE. If the D-dimer is positive, from a clinical standpoint, if the D-dimer is positive, you could do scoring systems like Wells criteria and really determining, all right, how likely is it that that D-dimer is positive because they have a PE? But at the end of the day, again, we live in a very litigious society, and of course, we want patients to be safe. So what are we going to do? We're probably going to scan them anyway, right? So just keep in mind, negative D-dimer, you've ruled it out. Positive D-dimer, you're going to have to scan them and confirm it. And that's basically, there are a couple I've seen, I think I know what you're talking about. There's like these long like flow chart things. I've seen them. I don't think they're actually very useful if you want my personal opinion. Um, I think just remembering D-dimer negative, you ruled it out, D-dimer positive, scan them. Does that make sense? Does that help? Was that your question? The other thing, speaking of D-dimers, we talked about sensitivity versus specificity. Okay, you're welcome. Sensitivity versus specificity. And people tend to get confused about sensitivity and specificity because the definition of sensitivity and specificity sound exactly the opposite of what they truly are, right? So if basically what's said, if you have a test that's highly sensitive, right? I'm going to give you the definition and I'm going to give you a very easy way to remember it, right? If you have a test that is 95% sensitive, right? 95% sensitive. What that is saying is that in 95% of patients, that's a highly sensitive test. In 95% of patients, there were no false positives for that test, right? There were no false positives for that test. So in 95% of patients, there were no false positives for that test, which makes you think that if it's highly sensitive, a positive rules in the disease, but it's actually backwards, right? It is, and the way that they wrote it is so confusing. So by being that sensitive, that 95% of people did not have a false positive, what they're saying is that if the test is highly sensitive, if you get a negative result from that test, you can effectively rule out disease, right? And I know the definitions, you read the definitions and you look at this and you're like, what in the world? Like, how in the world does this make any sense? But I'm telling you that it's the way that it's written, the definitions are so confusing. Some like researcher, like, I mean, I have a PhD, but I am not like a high level researcher. Don't get me wrong. Somebody with like a lot of research knowledge and a lot of whatever knowledge kind of put this all together, and it just makes no sense. With sensitivity, I gave you the definition, but remember, sensitivity has an N in it, right? N stands for negative. So if a test is highly sensitive, if it's negative, you have ruled out the disease. With specificity, They have tested the number of positive patients, meaning that the patients who are positive are definitely positive, and the patients who are negative are definitely negative, right? That's basically what specificity is saying. So what a highly specific test tells us is, because it has a P in specificity, if it's a positive result, you've ruled in disease, right? Does that make sense? And that's, I don't worry about definitions, worry about what I just said. Sensitivity, negative, ruled out disease. Specificity, positive, rules in disease. Because if you read those definitions, you're going to drive yourself nuts, and you're going to come back to me tomorrow and you're going to be like, you said that all wrong. It's all backwards. No, I'm telling you, this is exactly how it is. It is just so confusing the way that they put it together. The way they put those definitions together, I swear I will sometimes read those definitions. Like, I was actually just working on a project the other day and I had to talk about sensitivity and specificity. And I had to use a definition for something. And I was reading definitions again, and I'm like, wait a minute, I got this backwards. I'm like, no, stop it. You have been fighting over this for like 20 something, like 20 years now, right? Um, it is definitely sensitive and is negative. Negative rules out the disease. So a sensitive test, negative means no disease. Positive test, highly specific test, a positive test rules in disease. That's what it comes down to. Forget the definitions. Don't worry about what us PhD people decide to put into words, because it doesn't always make great sense. You're welcome. You're welcome. And now don't go back and try to read those definitions and confuse yourself. Just remember what I said, because I guarantee you somebody's going to come back and is going to write an email and say, I think you explained this backwards. And then we'll have this discussion again, and that's okay. Please feel free to send me that email and say, I think you explained it backwards, and I will explain it to you again. But the definitions make it sound backwards, make it sound completely backwards. All right. Anyway, let's talk about pleural fusion, and then we'll call it a day. All right. So pleural fusion, transudates versus exudates. Think transudates as water, right? It's free water. So think about congestive heart failure, constrictive pericarditis, cirrhosis. If it's an exudative pleural effusion, think cellular, right? Think thick cellular material, infection, malignancy, pulmonary embolism, stuff like that. Diagnostic criteria usually found on chest X-ray. If the effusion, if you need to further evaluate the effusion and you don't know exactly where it's coming from, you can do a decubitus view. And if it's greater than 1 centimeter in the decubitus view, then they recommend you do a thoracentesis. Most times with pleural effusions, you can figure out, oh, this patient's in a heart failure exacerbation. It makes sense why they have a pleural effusion, right? Like, nobody's like, oh my gosh, why is this pleural effusion happening? It makes sense why they have a pleural effusion. But if you need to further evaluate it, you can do decubitus study. If it's greater than 1 centimeter in the decubitus view, then they recommend looking at a thoracentesis. Do you need to know Light's criteria? No, I wouldn't worry about that for here, or at least for your exam. I would not worry about that. I'll be honest, I don't even think I've ever used Light's criteria. It's not even, to even go through Light's criteria, I'd have to look it up again and go through all the aspects, but I'm familiar with it, but no, I would not remember it for your exam. When you are testing that fluid, specific gravity, protein, LDH, obviously specific gravity is going to be low in a transudate because it's water, higher in an exudate because it's cellular material. Low protein in transudate because it's water, higher protein in cells, right? Low LDH in water, high LDH in cells, right? The one thing you do have to be very considerate of is if somebody has a pleural effusion that really has no clear picture as to why, the first thing that I would start looking for is cancer. I have a perfect example because I just had a patient very recently with this. And the whole situation is so bizarre how this came out. And the guy is only 40 years old. The guy is actually only 40 years old. So I had this patient, it was like maybe 4 weeks ago, maybe a month ago, 4 weeks ago, I had this patient, right? And I walk in and he already been there for like 24 or 48 hours. I don't remember. And he was there because his son, he was in his he was in his early 40s. His son and him got into an argument, and his son attacked him. His son, who's like in his 20s, attacked him with a broken beer bottle, right? Like, so smashed the beer bottle and went right for his face and got him pretty good, right? Like enucleated his eye. He had some pretty nasty lacerations. Luckily, we were able to save um part of the eye. We were able to, clean up his lacerate. Like, we got him semi fixed up. Um, but when he's on the floor and I'm looking at his chart and I see that he has a chest tube, and I'm like, wait a minute, this is all like facial injuries, and he went to the OR with ophthalmology and like all this other stuff. And I'm like, I don't understand. Why does this guy have a chest tube? Like, where did the chest tube piece come from? And I'm looking at his history and trying to find, like, okay, his like son kicked him in the chest, or he fell, or so, and there's nothing yet. And I'm like, what is going on with this chest tube? And he just has this like random pleural effusion, right? And that's why the chest tube, his pleural effusion was so big, they ended up putting a chest tube in to drain it. Yeah, psych is everywhere. This is very true. No matter what service you work on, you will find psych. Psych is a mainstay of every service, right? So I'm looking at this guy and I'm like, I don't get the chest. Like, where did this pleural effusion come from? And you know what? No, he had got admitted. That's what it was. He had got admitted the night before. And I said to one of my attendings that was there when he came into trauma admitting, I was like, the chest tube, did we do anything with this? And she's like, listen, we need to investigate this today because he just had this massive pleural effusion. I put in the chest tube last night. We really need to investigate this today. He just came in, it was like 4 o'clock in the morning or something. So, no, or maybe earlier than that, maybe like 2 o'clock in the morning. So she's like, nobody's, we're not getting anything done with that specifically at that point. So we definitely need to investigate this further. So I'm reading through, I told you we have to do like tertiary surveys on all of our patients, whatever. And I'm reading through his scans, and he has this remarkably large liver lesion on his CT of the abdomen as an incidental finding. And then he has like on the CT of the abdomen and pelvis, I also see like lesions in like the pelvic area and whatever. And the radiologist, usually radiologists will not clearly say like, hey, I think this is cancer, right? They won't say that. They'll say correlate with whatever. This is what we're seeing undifferentiated, recommend like MRI, recommend a biopsy, recommend follow, whatever, right? And this radiologist is one of the only times I've seen this in my career where they were very clear, like, this is basically clearly metastatic disease. And I'm like, oh, like, that's where the pleural effusion is coming from, right? He has metastatic disease, and because a healthy, otherwise healthy 40-year-old should not just have this random pleural effusion for no good reason, right? And sure enough, we did an MRI. And by that point, we were able to drain out some of that pleural effusion through the chest tube. And you could see there was tumor load under there. There was multiple tumors in the liver that even the CT didn't pick up very clearly. He ended up having lymphoma, is what he had. And last I heard, he was not. I don't think he was there this week. Yesterday when I worked. So I'm hoping he like went home and is going to do well. But from what I understand, he was not doing well. But he is the perfect example of a younger, healthy person with no reason for a pleural effusion should not just have some random pleural effusion sitting there. And when they do, you really need to think it's cancer until you've ruled it out. I mean, I wouldn't go up to the patient and say, hey, you have a pleural effusion, you probably have cancer. I mean, I wouldn't do that. But I would definitely be like, all right, we need to investigate this further. What else is happening here? People just don't get random pleural effusions, is my takeaway, right? So keep that in mind as well. If it's known to be from fluid overload, such as like heart failure or something along those lines, try diuresis and look for a resolution. Symptomatic effusions, if they're like short of breath with it or whatever, therapeutic thoracentesis and treating the underlying process. Infectious pneumonic infusions, antibiotic therapy for pneumonia, and thoracostomy tube could be placed to drain it out as well. Okay, so with that, we are just about 5:30. It's usually where I tend to cut off to give you guys a bit of a brain break. You have been here since 8 o'clock in the morning. Even with the breaks, it's a long day. And I leave, like I said, some extra time in for questions and stuff. You guys haven't had a lot of questions, which is fine as long as your questions are getting answered, right? But do you have any questions? I'm going to save the rest of the pulmonary questions for tomorrow, just in case there's something that relates back to vents or something like that that we're going to talk about with ARDS that we haven't talked about yet. So I'm actually going to pull my screen back to acute respiratory distress syndrome so that I remember tomorrow. Hopefully my computer stays just like this. So when we get here tomorrow, I remember to talk about this. And if I don't start talking, because I'm so used to ending and then picking up with pneumothorax on day 2. So if for some reason tomorrow morning I try to take you through pneumothorax and hemothorax again, please stop me, right? Please tell me to knock it off and go back and talk about ARDS because that's where we pick up. So we'll talk about tomorrow. We'll pick up with ARDS. We'll do 2 questions in ARDS. We'll do the rest of the questions in the pulmonary chapter. And then we have cardiovascular, GI, renal, and neuro. All right, good. I'm glad that was my next question. Is everybody enjoying the course so far? And somebody said it's been great. Thank you so much. So thank you. You are very welcome. I'm glad you are enjoying it. Any other questions before we go? You're welcome. All right, bunch of thank yous. So you are very welcome. How do the questions we've gone over compare to the board exam? They're similar. They're similar. Some of them are more basic, because I'm just trying to make sure you're remembering information. Some of them are more complex than what's on the boards, and some of them are more on key what's on the board. So there's a mixture there. Well, you guys are welcome. Are we going to be talking about ventilator management tomorrow? Not specifically about ventilator management. We'll talk about vents and some concepts of vents when we talk about ARDS, but not specifically ventilator management techniques. We will talk about vent weaning. We'll use the same link for tomorrow's class or get a new link. I believe it's the same link. All right. Any other questions? All right, everyone. Well, go take a rest. We're done, about 20 minutes early, but that is okay. Go take a rest, go relax, and come back tomorrow, fresh and ready to go. I hope everybody is enjoying the class so far. And if you have any questions tomorrow when you come in, feel free to dump them right in the Q&A box. I will always start day 2 off with some questions. So if you have any questions there, just feel free to dump them right into the Q&A box. And otherwise, enjoy the rest of your evening, and I will see you tomorrow. Have a good night, everybody.